Hi, boss.
Hi.
हाँ धर्मेंद्र क्या हाल है?
Hi, Dharmendra, how are you?
Sir, boss, morning. Bhaiya, boss.
Sir, now you can start, sir.
Hello, Ajay, boss.
हेलो धर्मेंद्र.
Okay, so we can start now.
Yes, sir.
Well, so good morning, friends. And on this Sunday morning, I welcome you all on this virtual platform where we'll be discussing the various aspects of heart failure, and it will be more focused towards the heart failure in India. As you would know, we are having huge burden of this disease. It's a final common pathway of all cardiovascular disease, and we have very good, eminent faculties, all good friends are joining us here, and they'll be discussing right from the burden of heart disease, heart failure patients in India to, what all we can do medically. And then we would also look at the revolutionary molecules which have changed the shift, taken the management to the next level of the heart failure, and also the, end stage heart failure, or what we call, frequent flyers with heart failure. These patients would need some kind of devices. So we'll have some brief discussion about the devices also, and also the, because we are offering these patients, left ventricular assist device, the artificial heart, also the left, heart transplantation. We are only center in North India where we are giving, heart lung transplant option to the patients who have got, severe PH, Eisenmenger kind of patients. So I think whole gamut of things is going on, but prevention is better than cure. We know if we recognize the heart failure early in the inception and initiate the therapies, then probably, the burden can be decreased, the overall outcome can be the can be, made much better. So with that perspective, I had, taken this that we would have the program in first session. I would invite the chairpersons, Dr. Naresh Goyal, who is a very good friend and right now Director of Cardiac Sciences at BL Kapoor Hospital, which is, different name of Max, so he's in BLK Max. Then we have got a very good friend and uh, one of the happiest physician and cardiologist and diabetologist, Dr. G.S. Kohli. Welcome, Dr. Kohli. And also Dr. B.K. Tripathi, who is the head of medicine from Safdarjung Hospital. So welcome, Dr. B.K. Tripathi. I think he has not joined. Vasu, just check with him. Has he joined?
Yes, sir.
And then we have got very good friend, who had worked with me. I had the pleasure of working with them. My, Dr. Ajay Pandey, who is head of cardiac sciences at Galaxy Hospitals in Varanasi, and we have been, doing cardiology for ages together. And he's been, my childhood friend as well. So it's like a friendship uh, blossoming in the background of cardiac practices. Also, I have Dr. Abhineet Gupta, who was, you know, passed out from AIMS, New Delhi, did cardiology and did some time. He worked for a couple of years with us at Max Hospital, but he chose to go to Kanpur. So he's, interventional cardiology and director of cardiac cath lab at Regency Hospital, which is a very famous hospital in Kanpur. Dr. Dharmendra Jain, who is again a professor and head of Department of Cardiology at prestigious Banaras Hindu University, and Dr. Vinesh Jain, who was again a colleague of mine working here, and he opened his own hospital, Rainbow Hospitals, with cath lab in Agra. So he's a very, very, renowned cardiologist there and very aggressive interventionist out there doing interventions with, imaging and all these things. And so he's again joining here. We have slight change in the program. After Dr. Avneet Gupta, Dr. JPS Sahni, who is again, a stalwart in the field of cardiac sciences, and he kindly agreed to, give his precious 15 minutes to us. But his condition was that his talk should be preponed and be in the first session. So I'll request after Abhineet Gupta, chairpersons, kindly allow Dr. JPS Sahni to, deliver his talk, and then things will be in the same sequence. So may I hand over the proceedings to chairpersons, Dr. B.K. Tripathi, sir, Dr. G.S. Kohli, and Dr. Naresh Goel. So over to you, sir. Please start the proceedings.
Dr. Goel, you are muted, I think.
Yeah.
Hi, good evening. Good morning, Dr.
Yeah.
Viveka. Thank you, Dr. Viveka. And good morning, Dr. Kohli.
Good morning. Good morning.
Hi, sir.
Hi.
I think let's start it. All the stalwart has joined and a lot of audience has also joined. So it's wonderful to have a discussion over the heart failure the Sunday morning. I think there's a new things has come up in last few years. So it's good to refurb that, refresh that all the knowledge what we have and how to practice and how to change to get the information from each other, that what can we do and what else we can offer. It's a really wonderful initiation by Dr. Viveka to start and to discuss this topic about this thing. So I think let's start it.
I think the first topic they have said is heart failure in India.
Yeah.
Yeah. So heart failure in India, they say the estimated prevalence of patients of heart failure is between 1.4 to 4.3 million. And apart from the Western factors like hypertension, ischemic heart disease, we have a huge burden of rheumatic heart disease as well to contribute to the load of heart failure. So to talk about all this, I think we should invite the first speaker, Dr. Ajay Pandey, who is a renowned cardiologist. So Dr. Viveka, can we start right now?
Yeah, we can start. So I'll request Dr. Ajay Pandey to share the slides. Dr. Pandey,
Thank
can
you
share
and
the
good morning to chairpersons and all faculty members here. And at the outset, I'm really thankful to my colleague and friend, Dr. Viveka, who always, asked me to join his endeavor of academics whenever he start these type of program. I really congratulate him for his, this endeavor. May I share my slides, please? And this is my slide
Yes,
visible to all of you?
Yes, we can see.
Yes.
So the job assigned by me to me by Dr. Viveka is discussing regarding the heart failure, the Indian perspective. As Dr. Kohli was already discussing, that heart failure is a big burden not on our own country, but it's all across the world. If you see different parts of the world, starting from Northern America, Canada, USA, the prevalence is around 1.5 to 1.9%. But when we come to the Asian countries, China, Japan, Malaysia, Singapore, and in our own country, the prevalence is quite frequent. But the expected prevalence is around 62 million adults. Though they are having adults worldwide are estimated to having heart failure. But the aging population, increased prevalence of risk factors like diabetes, hypertension, and in our country, rheumatic heart disease is also one of the important factors, as well as post-MI. They are increasing the burden all across the world. But if you look to particularly in India, there is an iceberg tsunami. And because cardiovascular disease is the leading cause of morbidity and mortality in our country by 2020, in India, basically it's a home of around 16% of the global population, but around 25% of the world's coronary heart disease CHD burden is in our country. And around 120 million hypertensives are there in our country. So a large number of individuals with rheumatic heart disease are also there. So the projected burden of heart failure in India is around 10 million or about 0.9% of the total population. And the reason for that is, because the history of MI is around 21 million by the above the age of 19. Heart failure due to MI is around 2.1 million to 8.4 million. Heart failure due to hypertension is around 3.5 to 7 million. But the annual mortality due to heart failure is around 0.1 to 0.16 million. There are multiple risk factors for that. And the prevalence due to coronary artery disease is in the range of 3 lakh to 1.75 million, but it varies due to hypertension, diabetes, and obesity. So these are the leading important causes of heart failure in our country, and it's a bigger challenge in all across the Indian subcontinent. If you look into the global and Indian perspective, what we find in a global perspective that the mean age are elderly people around 73 years or so, with a hospital mortality of around 3.8% and post-discharge mortality at 6 months around 8.6%. But in our own country, the mean age is a younger generation, around 53 years or so, with a mortality of just around 10 times of the global mortality, and around in-hospital mortality is 30.8%, with the post-discharge mortality at 6 months is 26.3%. So the patient with heart failure in India basically are younger at age and very high mortality both in hospital and after discharge. And doing this, if there's a inter-CHF study where heart failure in low and middle socioeconomic with the background, rationale, and design of international congestive heart failure has been done, and which is published in 2017. And the study has enrolled hospital inpatient and clinic outpatient around 66 to 34%. Of them, there are 5,813 patients were there from 108 centers with the 6 geographical regions, and India is among one of them amidst the Africa, China, Southeast Asia, and Middle East. The key characteristics which was seen in inter-CHF study was our population having much younger and had a little education. They are more symptomatic, low rates of health insurance, and more often from rural area and more often treated with digoxin. So, and outpatient versus inpatient, if you see the unadjusted mortality in India, the unadjusted mortality in inpatients were pretty high compared to other countries, except that Africa has got the similar type of pattern. And CV mortality, if you look into this study, because of cardiac death, it is pretty high compared to non-cardiac and unknown causes of death at 1 year by this study. But if you look into our own data, the most important data came from Trivandrum Heart Failure Registry. And the Trivandrum Heart Failure Registry, which was published in American Heart Journal in 2017, has revealed it's basically a prospective hospital-based registry covering both the urban and rural area. And they're divided into the 2 groups based upon the ejection fraction. They have taken the ejection fraction with preserved ejection fraction patient of EF more than 45%. Though now the classification was more than 50%, but in that study they have taken more than 45% as HFpEF and HFrEF as less than 45%, and around 1,205 patients from 18 hospitals followed for 1 year, and the patients were categorized as receiving the guideline-directed medical therapy and a suboptimal care during the initial enrollment. And to evaluate the hospital readmission and 1 year mortality outcomes in patients with heart failure in Kerala, India, the data which came out from Trivandrum Heart Failure study that hospital readmission at 1 year is similar across the genders of men and women around 30%, with a similar irrespective of ejection fraction, whether it's a HFrEF or HFpEF around 30%. The 24.4% were readmitted, and 1 year hospitality and readmission rate was pretty high, around 30%, and 5.4% were readmitted more than once. The factor increasing the hospital readmission is basically the NYHA functional class 4 symptom during the index hospitalization, as well as the suboptimal guideline directed medical therapy. So my friends and Dr. Viveka's endeavor to educate and to to make people more aware about the heart failure therapies and the guidelines will definitely help them to inculcate this guideline directed medical therapy, and that will particularly impact the overall practice pattern of our patients. The Trivandrum Heart Failure study has come up with other findings that around 1/3 of the heart failure patients die within 1 year during their productive life, and around 18% have a greater risk of mortality in the first 3 months. 61% had death at 1 year, or those who are having age less than 70 years, and mortality rates are greater in heart failure patients. And the factors which are important for mortality are age, particularly elderly people. They are more prone for death and more mortality. History of stroke, high serum creatinine level, suboptimal guideline-directed medical therapy, the most important part which was highlighted, and were on more hospital readmission. So, for frequent hospitalization is another important factor, and hospitalization burden in India is basically a big challenge. And 1 out of the 3 patients are admitted in our country, and 1/3 of heart failure patients die within 1 year during their productive life year. So that's a quite a significant number. And the hospital readmission leads to the higher mortality, because 1 year mortality rate was significantly higher in patients who had more than 1 hospital readmission. You can see in this graph, that the no readmission versus readmission more than once has quite significant diversion rates. The patient who did not receive the guideline-directed medical therapy, they have got definitely a higher mortality rate as compared to the guideline-directed therapy. And mortality remains high in Indian patients over time, whether you compare in hospital or more than 6 months, it is around 13 to 38%. And as the time passes, the mortality remains higher and higher. So the clinical investigation, this Trivandrum Heart Failure Registry, the 3 years outcome of heart failure patients, which was published in the Journal of Cardiac Failure in 2018, what they have seen that the different duration of index hospitalization, in hospital mortality, cumulative 30-day mortality, they all have been compared, and this was noted that definitely in hospital mortality and cumulative 30-day mortality was quite significant in this study, and heart failure type and long-term mortality rate was particularly higher in HFrEF group of patients. Like HFrEF is a red line compared to HFpEF patients. So we all know that HFrEF patients are more sicker, and the long-term readmission and mortality rates in Trivandrum Heart Failure Registry was for definitely high for definitely those who have got more than one readmission. So as the data suggests, and if they are on even though they have got a HFrEF and but admissions more than one readmission, definitely their mortality rates were high. People, those who are on guideline-directed medical therapy and without guideline-directed medical therapy, the mortality difference was there. So I need to conclude that heart failure is a big challenge in our country, and the reasons behind that, and what we have found in our own studies, particularly from southern India, that the people are much younger, they are more symptomatic. The suboptimal therapy, it's a real important aspect. Having a little education about the heart failure treatment outcomes, low rate of health insurance, and more often from rural areas. So if we improve the quality of our heart failure programs and adherence to the guideline-based medical therapy, definitely it will reduce the readmission and improve the outcomes in our country. So that's all regarding the heart failure in Indian perspective from my side. Now it's over to the other speakers.
Dr. Ajay,
Yeah.
with state-of-art CCU facilities and with such a good cardiologist team, why the mortality in hospital is 10 times than the Western part?
Because you might have seen that in spite of so much of best possible cardiology team in Kerala, still there is a lot of suboptimal guideline directed medical therapy. People are having more and more of a hypertension, CAD, because there are multiple factors are operating.
But is it something to do with the patient's factor?
Patient factor as well as the physician factor, because the patient factors are there as far as the increasing number of hypertension, coronary artery disease, and other cardiovascular diabetes, and all those risk factors were there in this group of patients, as well as the suboptimal medical therapy was also very important. Because if you this data I have not seen into that how many of them are because of the suboptimal guideline directed medical therapy was the physician's perspective, because we as a physicians are not giving them an adequate guideline directed medical therapy, because many times we are scared of adding all the important drugs. What to speak of our own country, people in Western population and different the other multicentric studies also, the people with the guideline directed medical therapy, they are not on adequate beta blocker, ACE/ARBs and melanocorticoid receptor antagonists. They are usually on 60-70% or so. So that's the physician inertia is always there, and that's also one of the important factors in spite of patient factor and the disease burden itself.
Thank you.
Great. So I think that was wonderful talk. And as I said, there was a slight change. So Dr. Sahni, are you ready? We can have
Yes,
talk.
you can see my slides.
Yeah, we can see the slides. So I'll request Dr. Avneet Gupta and this session's other speakers to just allow Dr. Sahni to deliver his talk.
Thank you. Thank you very much, Dr. Vivek and dear friends. Listening to Dr. Pandey's brilliant talk on the overall prevalence of the heart failure. I want to just add before going to my talk that we have also had been participated in Asian heart failure trial. And again, like the Trivandrum heart failure registry, our population is approximately 5 years younger than that of the Northeast Asian population. These were 11 countries heart failure study where we participated, and we gave 2,000 patients out of the total 6,000 patients in Asian heart failure. And we were younger, definitely, but much younger in HFrEF compared to HFpEF. And we had more comorbidities like diabetes and the coronary artery disease. And when we look into the mortality and morbidity, we were better than Southeast Asia, where we have countries like Philippines, the Vietnam, Thailand, but we were certainly not as good as Japan and China. So that is sure that probably it is a multifactorial. Probably it is the comorbidities, and also, as Dr. Pandey rightly said, guideline-directed medical treatment is not very well followed in many patients, as we saw in Trivandrum heart failure history. So coming to the management of hospital, I see Dr. Pandey has shown that as there is a recurrent hospitalization, there is increased mortality in heart failure population, particularly HFrEF population. So my talk is on management of hospitalized HFrEF patients. It is a case-based discussion, basically discussing about the cardiac remodeling, how if you do not do adequate cardiac remodeling, then probably there is a further progression or a deterioration in the LV function, leading to early mortality. So I will just straight away go to the, I can't check the, that slide is not moving. Just check it. I can check it. Yes, no, it's fine. So let me go to straightway to the case. This is Mr. David, 65-year-old patient of HFrEF. He has been recently hospitalized. He's a known case of HFrEF and recently hospitalized with acute heart failure. He was having symptoms of breathing and was unable to do daily routine activities. And he was rushed to the hospital with acute breathlessness. And when we look into the clinical history and his investigations, echo showed ejection fraction 32, global longitudinal strain, which we do these days routinely in echo, was less. It was 15%, anti-BNP was high, and echo did show that the end diastolic volume and systolic volume and the left atrial volume were all on the higher side. And after hemodynamic stabilization, this patient was already on chronic heart failure treatment. We have to start a guideline-directed medical treatment to improve his cardiac structure and function of the heart. So coming to the remodeling of heart failure patients, we know that the remodeling is a major risk factor in progression of heart failure. We know that once there is a myocardial infarction, the cardiac myocyte and extracellular matrix, they are damaged. At the same time, there is a neurohormonal activation of ROS system and sympathetic system that gets activated. And finally, there is apoptosis, fibrosis, and ultimately hypertrophy of the ventricle, which all factors that lead to inappropriate remodeling and progressive aggravation of left ventricular function, which leads to progression of heart failure. And we know in the natural history of chronic heart failure population, there are repeated admissions have been seen in patients, those who are not getting adequate medical treatment, those who are not given appropriate remodeling treatment. So the prognosis of the patient with heart failure can be evaluated by monitoring the cardiac remodeling with echocardiogram. And we look particularly into three factors, basically LV systolic function, structure and shape of the function of the valve, particularly mitral valve, and then look at the LV diastolic function. In LV systolic function, EF is very commonly measured and is found to be very commonly used marker for the outcome of the CV outcome and even for prognosis. Left ventricular end diastolic volume or diameter is again a very good parameter of LV systolic function and degree of structural remodeling. Similarly, end systolic volume is the best parameter to evaluate the prognosis in patient with LV function. Coming to the shape and function of valve, mitral valve regurgitation is very commonly involved in one of the parameters which is evaluated. The severity of the mitral regurgitation is also very well known as the secondary changes of the heart failure. For diastolic function, the mitral inflow is one of the diastolic dysfunction which variables with the E to A ratio of more than 2 is generally indicated of a restrictive inflow mitral pattern and which reflects the diastolic dysfunction. So the Cardiac remodeling in hospitalized patient, progression of the underlying cardiac dysfunction with ventricular remodeling is important. Echocardiography, as I said, is playing a major role. Remodeling is also through echocardiography and can predict the future heart failure mortality and hospital readmissions. This has been seen, studied already, and then remodeling patterns have been seen, various type, eccentric, concentric, and even concentric hypertrophy have shown clearly that the cardiovascular mortality, reinfarction, heart failure, stroke, sudden deaths are all related to the cardiac remodeling. The risk of cardiovascular death and heart failure hospitalization increases significantly with decrease in the left ventricular ejection fraction. This has been studied very well in CHARM trial, more than 7,500 patients, almost 15 years ago. And they have clearly shown that if EF drops by 10%, then there was an increase in cardiovascular mortality and hospitalization by 45%. And cardiovascular mortality alone, if you look into that, goes up to almost 60%. So that is very important parameter, a marker, which gives you an idea about the future prognosis of a patient of chronic heart failure. So coming to the other parameters, which we have just discussed about the echo, with the help of echocardiogram, and that is the end diastolic volume and end systolic volume. Both of them have clearly shown in the studies that if there is an increase in the end diastolic volume by 10 ml, we know the normal is between 60 to 120 for basal surface area. And if it is increased by 10 ml, there is increased mortality and hospitalization by 9%. At the same time, the left ventricular systolic volume, if it increases, is the worst prognostic marker compared to diastolic, and that shows approximately 15% increase in the heart failure and hospitalization. This is the study. Then 6 months CRT treatment was given to the patients. Long-term mortality decreased significantly in patients with left ventricular ejection fraction and end diastolic function. Those who have shown improvement versus those who did not show improvement with the CRT. So this is a study that has been done and very clearly shown if there is an improvement in ejection fraction. You can see the quartile 4 is by more than 30%. There is a significant reduction in cardiovascular mortality. On the right hand side panel, you can see that there is they look into the end diastolic volume index in this population, and similarly they have shown when the volume index is reduced by more than 20%, there is a significant reduction of mortality. So both the parameters, the EF as well as end diastolic volume, have shown a clear-cut benefit in if you give treatment medical treatment along with CRT, there is an improvement in the treatment management. Coming to the there is some problem again. Yeah, that's good. Yes, that's right. Thank you. So long-term mortality decreased significantly. If you look into the other third parameter, left ventricular systolic volume index, again, which we discussed already, the mortality was decreased by almost 68% in patients with heart failure with systolic volume index, which is decreased by more than 15% compared to less than 15%. So overall, as we have just discussed, that there is a reduction of the left ventricular systolic volume, you get a reduction in mortality by around 14 to 15%. So with this basic understanding about the remodeling, which we have learned from the echo parameters, the choosing a right medical treatment is always important to reverse the cardiac remodeling in HEPREP population. And for that, we are sure that yes, we have the HEPREP therapies in our armamentarium, which can reverse cardiac remodeling in hospitalized patient. Yes, as in our patient of David. Yes, we have available. And now this is a drug, the ARNI, which is a combination of sacubitril and valsartan, which is very well known to improve the cardiac remodeling by inhibiting myocardial cell death and hypertrophy. And what we have learned, the sacubitril reduces cardiac myocyte, improve the cardiomyocyte contractility, reduces the cardiac myocyte death, and valsartan by reducing the cardiac myocyte hypertrophy and reducing the extracellular matrix remodeling. But combination, they have a complementary action to each other, which ultimately improves the cardiac remodeling in patients with heart failure. These are the data which come from the paradigm heart failure trial, and they have shown that when the ACE inhibitor versus the RNA, comparing baseline versus follow-up at 3 to 6 months or even 1 year, they have shown that the ejection fraction was significantly improved in the patients, those who are on RNA compared to that of ACE inhibitor. You can see here from 27 to 35. So improvement has been seen in this RNA compared to ACE inhibitor. When they look into the other parameters, the echocardiographic parameters, they look into the end diastolic volume, which has reduced, the end systolic volume reduced, left atrial volume was reduced much more with RNA compared to the RAS blocker or ACE inhibitors. So patient treated with RNA shows improvement in echocardiographic patterns much higher, and this is again subgroup analysis from the paradigm heart failure trial. So the other fourth parameter, which these days we do in echocardiogram, is the GLS, what we say global longitudinal strain of the patient, is generally in abnormal range. It is in fact, the earliest parameter to pick up before the reduction of left ventricular ejection fraction, much more sensitive and much more reproducible factor of echocardiogram. And so myocardial strain can be used for the objective and reliable assessment of systolic function. Is generally done by the two-dimensional speckle tracking that can provide information the rate of segmental and global myocardial deformation. We generally take the apical view. It is a simple, feasible method with good, excellent reproducibility, and GLS helps in predicting mortality and hospital readmission in patients, different cohort patients of heart failure. It's a very strong, independent prognostic factor for outcome in patients with heart failure, independent of left ventricular ejection fraction. So this is a study which have shown in acute heart failure population, the stabilization. They have looked into the global spread. Normal, we know the GLS is about 18, on average around 20, below 16 is considered abnormal. And they have found that there is almost 8 times increase in risk of heart failure readmission if there is a fall in GLS by more than 6%. Patient treated with RAS blocker ACE inhibitor versus the RNA, there was a difference, and we can found that the benefits were much more with the RNA. So in a hospital setting, do they have, the RNA has a effect? Yes, it has effect, as we have seen, and now we have a data from the studies, and they have shown that the reduction of GLS, as you compare with the baseline at a follow-up of few months, they have shown a significant reduction in the improvement in the GLS, what we can see in the patients of heart failure, which was 2.76% reduction in GLS with the in patients with acute compensatory heart failure compared to the RNA or compared to the ACE inhibitor. So to summarize, dear friends, I want to say that in hospitalized heart failure patient with reduced ejection fraction with impaired cardiac functions, like we saw in David, our patient, the time is essential. We should start treatment early. So initiating early sacubitril valsartan with confidence is very important. We have got the data, not only in the paradigm heart failure trial, which have clearly shown benefits in primary, secondary endpoint, the hospitalization of heart failure, the mortality reduction was clearly seen in paradigm heart failure trial. And initiating this drug early in the treatment modality will be always useful. And this has been proven by the pioneer trial of which was where RNA was used, and then the pioneer trial did show that initially starting within few days of starting after stabilization of heart failure, this population can go into get much more benefit instead of waiting for 2 to 3 months to start the drug, because the guideline directed medical treatment have shown that if you start this group of drug, and our own observation is there, our own experience is that a lot of patients, they improve their ejection fraction. That's why now there is the 4th classification of heart failure after the HEPREF with mid-range ejection fraction, the HEPPEF, and 4th one is now heart failure with improved ejection fraction, or what we say heart failure with recovered ejection fraction, where patients have ejection fraction less than 40%. With the help of treatment, particularly now with the ARNI and SGLT2 inhibitor, we are observing, I'm sure all of you are observing, an increased ejection fraction above 40%. So they are the patient of HEPREF in remission. And these are the patients they are able to achieve only with the help of the ARNI as one of the important drug for the management of heart failure. And based on that, now ESC guidelines and other ECC guidelines have clearly shown that in patients, they have started now that it is the ARNI has shown a proven benefit in acute decompensated heart failure and has received an ESC consensus recommendation for first-line treatment in acute decompensated heart patient after the stabilization, after the intravenous diuretic treatment has been stopped, and we have put them on oral drug and starting all the 4 drugs together over a period of 4 weeks to improve the treatment modality and also to reduce the cardiovascular events. I think I can stop here. Thank you very much for listening to me. Again, it's good. Share.
Thank you, Dr. Sani. You have beautifully outlined the cardiac changes and the functional changes in HFrEF patients. I want to ask one question. Many of the diabetics, say around 21%, have got asymptomatic heart failure. So you can only recognize them by finding left ventricular diastolic dysfunction. So your suggestion is that should we do echo in all diabetic patients to identify such patients?
Well, the guidelines of diabetic for detecting the asymptomatic cardiovascular disease have only asked at the moment to use only ECG and microalbuminuria. But yes, what my suggestion is, if the diabetes patient is for some duration and has got comorbidities like hypertension, dyslipidemia, I think doing echo, and we have learned now with the various studies that the instead of MACE is not the important. MACE comes later, the heart failure comes earlier. And among the heart failure, diastolic dysfunction comes earlier. So I think if you want to detect the diastolic dysfunction, then the sometimes patient may not be symptomatic. Doing an echocardiogram and looking at the diastolic dysfunction parameter on the echo will be a good idea to give a type of guideline to patients that, yes, you are having diastolic dysfunction and you are prone for future cardiovascular disease. So you have to be on guideline-directed medical treatment, and also some of the drugs like SGLT2 inhibitor, which are known to prevent heart failure in future. So such type of treatment modalities can be discussed with patient and share with him. So I think I agree with you that in significant number of patients with diabetes, the echo should be done.
Thank you. I think now over to Dr. Tripathi to start the next session.
I think Dr. Tripathi is muted.
Dr. Tripathi, please unmute.
I think there's some technical issue out there. So let's request Dr. Abhineet Gupta to share his screen and deliver his talk on the risk factors for the heart failure. Dr. Abhineet Gupta. You're muted, Dr. Abhineet. We can't hear you.
Yeah. So thank you, sir. You have always been an inspiring mentor for me. And with the permission of chairpersons, may I start my session? So
Yes,
I'll be discussing about the risk factors for heart failure. And we have already learned that heart failure is now a progressive disease and the prevalence is increasing day by day. And I think in future, we'll see more and more number of cases of heart failure because the population is aging and there are better treatments available for coronary artery disease and other common causes of heart failure. So heart failure is reaching an epidemic proportion in aging population with increasing burden and cost projected over the next 2 decades. It results from several different etiological pathways and each influenced by wide-ranging individual, clinical and environmental risk factors. Rough estimate of prevalence is around 2 to 3%. We have already discussed in detail, and worldwide almost 60 million or 6 crores they are suffering from heart failure, and the prevalence seems to be increasing. The lifetime risk of developing heart failure is around 1 in 5. The classification, we already are aware, mostly it is HFrEF and HFpEF, and in between there is heart failure with mid-range ejection fraction. So obviously the risk factors, they have to be different depending on the type of the heart failure. Broadly, the causes are numerous, and on the left-hand side, these are the common causes like coronary artery disease, hypertension, valvular heart disease, arrhythmias, various cardiomyopathies, and some congenital heart disease. And on the right-hand side, these are some uncommon causes like infective etiologies, various drugs like as anthracyclines, trastuzumab, anti-cancer therapies, infiltrative disorders, storage disorders, some endomyocardial diseases, metabolic causes, and finally some rare neuromuscular diseases like muscular dystrophy and Friedreich's ataxia. So basically, coming to the main part of the presentation, that is the risk factors for heart failure. Till now, CAD used to be the underlying etiology in almost 2/3 of the patients of systolic heart failure or HFrEF patients. But now the etiology and pathophysiology of heart failure is undergoing a transition. With the decline of coronary artery disease, hypertension and type 2 diabetes have now become the most common etiologies of incident heart failure. And probably the better treatment available, better and timely treatment for coronary artery disease, more and more application of timely window period percutaneous angioplasty, as well as widespread availability of cath lab facilities is also one of the common important cause of decline in coronary artery disease. Age, smoking, physical inactivity, obesity, and lower socioeconomic status are other overlooked risk factors for heart failure. So if we see, any road can lead to heart failure. A patient of hypertension can progress to heart failure. A patient of diabetes and obesity, which we call as diabesity, can progress to heart failure. Smoking is a common risk factor, valvular heart disease and coronary artery disease, obviously. So if we see the data from various epidemiological studies, the relative contribution of various risk factors to the development of heart failure remains controversial and has seldom been investigated properly in population-based studies. If we talk about the Framingham heart study, hypertension contributed a large proportion of heart failure cases, particularly in female population. Further, obesity was associated with a doubling of risk of heart failure and was responsible for estimated around 14% heart failure cases in women and 11% in men. Another study, that is the National Health and Nutrition Epidemiological Survey, suggested that CAD was the most important and most common cause as a risk factor for the development of heart failure. And as per the NHA-NES, CAD alone may be responsible for more than 50 to 60% of cases of heart failure. We have got 2-3 studies which have addressed the issue of risk factor for heart failure, and one of them is a study by Shannon M. Dunley, which was published in the American Journal of Medicine in 2009. It was a population-based case control study which included almost 1,000 patients. The mean age was around 75 years and 53% were women. Women were older than the men, and this study found these 5 risk factors for heart failure. The most common risk factor was hypertension, followed by history of smoking, followed by coronary artery disease, then obesity, and then diabetes. And if we see the odds ratio, so clearly the odds ratio of coronary artery disease is the highest, that is 3.05, which is followed by diabetes, 2.65, followed by obesity, and then hypertension and history of smoking. Another study, so basically in this study, hypertension was the most common among the incident heart failure cases, occurring in around 66% of the patients, while the onset of hypertension or obesity preceded heart failure by an average of more than 10 years. Heart failure occurred much more rapidly after coronary disease. For coronary artery disease, sudden cardiac events like myocardial infarction may lead to quickly cardiac dysfunction, which can culminate into heart failure. On the other hand, hypertension, diabetes, and obesity may lead to heart failure over longer duration via multiple pathophysiological mechanisms, which can include myocardial metabolic dysfunction, oxidative stress, endothelial dysfunction, all leading to progressive ventricular remodeling and cardiac dysfunction. Another study, which was basically a meta-analysis and that was published in the British Heart Journal by Young H. et al. It showed that the hazard ratio of coronary artery disease was again the highest, that is 2.94, followed by diabetes, that is 2.0, age more than 10 years, the hazard for each increase in the age by 10 years, the hazard ratio increases by 1.8. Hypertension, the hazard ratio is 1.6, followed by smoking, gender, and increased BMI. Another 20 years population-based study, which was published in the Circulation in 2020, showed that previous studies have reported an increasing trend in the ischemic cause over time, but detailed trend analysis in this study shows that there has been a shift to stable or decreasing proportion of heart failure patients with ischemic heart disease over the past 10 years. And the prevalence of diabetes, obesity, hypertension, chronic kidney disease, and cancer comorbidities at onset are increasing. And these factors may be associated with an increasing prevalence of heart failure with preserved ejection fraction. So ultimately, all roads, they can lead to heart failure. So coming to a few individual risk factors, coronary artery disease, it used to be the most strongly associated risk factor for heart failure. It should be considered as a possible cause of heart failure in all patients presenting with new onset heart failure. Documentation of ischemia using non-invasive and invasive tests can be difficult in patients with heart failure because of the possible exercise intolerance and the effect of increased and diastolic LV pressures. Coronary angiography or CT coronary angiography can be performed to establish the presence and extent of coronary artery disease and evaluate the potential indication for revascularization. Hypertension is a leading risk factor for the development of heart failure. Almost 2/3 of heart failure patients have a past history of hypertension, making it the most common risk factor associated with the development of heart failure. Hypertension is also the most common cause of HFpEF with a prevalence of around 60 to 90%. Diabetes, it increases the risk of heart failure twofold by directly leading to cardiomyopathy and also indirectly by various other pathophysiological mechanisms like the development of atherosclerotic cardiovascular disease, associated hypertension, metabolic disturbances, cellular impairments, structural alterations, AGE deposition, cardiac autonomic neuropathy, as well as activation of RAS system. It is also one of the strongest risk factors for heart failure in women with CAD. Obesity is a risk factor for hypertension and coronary artery disease, and thus is also associated with an increasing risk of heart failure. Again, there is possibly a stronger association with HFpEF. Obese patients have also got an obesity paradox, which is described such that overweight or mildly, moderately obese patients have a better prognosis than leaner patients, particularly compared with those who are underweight. Obstructive sleep apnea is the most common but least recognized comorbidity, and almost 70% of heart failure patients have got OSA. AF also frequently coexist and they can cause or exacerbate each other. When AF causes heart failure, the clinical course seems more favorable and mostly tachycardiomyopathy has got a good prognosis. On the other hand, if the patient of heart failure develops AF, then obviously the prognosis is worse. Chronic kidney disease also is an important risk factor and they share common risk factors. CKD may worsen cardiovascular function, causing hypertension and vascular calcification, and sometimes oxidative stress and fibrosis may also play a major role as a pathogenic mechanism in heart failure with CKD patients. Cancer, patients of cancer can also have heart failure because of various complex interactions among the anti-cancer therapy, cancer itself, and patient's cardiovascular background. And many of the anti-cancer drugs have got cardiotoxic mechanism and they can ultimately lead to development of heart failure. Coming to the summary, while advances in the medical therapies have led to improvements in survival after heart failure diagnosis, prognosis and disease burden still remains significant. The best strategy for avoidance of morbidity and mortality from heart failure is prevention, as Dr. Viveka has already mentioned. Hypertension, coronary artery disease, diabetes, age, smoking, male gender, and increased BMI. So these are the important risk factors which have been shown to be associated independently and consistently in various studies with the development of incident heart failure. Other risk factors being atrial fibrillation, left ventricular hypertrophy, and valvular heart disease. Although heart failure may be prevented by control of heart failure risk factors, early detection of LV dysfunction may facilitate the caregivers for early institution of measures that can prevent progression of the problem. Thank you.
Thank you, Dr. Gupta. We quickly move on to the next session. Having recognized heart failure as a leading cause of morbidity and mortality, how to diagnose this? As we know, the main symptom of heart failure is breathlessness. And 30% of cases of heart failure are associated with COPD. So we need some diagnostic tools or some biomarkers to identify the patients of heart failure. So the next speaker will be highlighting this point. He is Dr. Vinesh Jain. So he will be highlighting on the diagnostic tools and the role of biomarkers in diagnosing heart failure. Any comment from Dr. Naresh Goyal, please?
Dr. Goyal, you are muted, sir.
Now, I just want to say that for the previous talk, that it was very nicely described, the risk factor, and it's a really most important thing in the treatment, the prevention of the heart failure development. Because what we are discussing as the management of heart failure, but if we take care of the risk factor, we can delay the progression and the development of heart failure. And I think this is that really we should carefully take out that all the risk factors that have been discussed, like obesity, hypertension, diabetes. These are not just for saying these are really important in particularly heart failure, because as we know that we nowadays having good treatment of our heart failure, but still it's a largely not kind of a good treatment at present we have. So the prevention is the best strategy, and if we take care of the risk factors, we can definitely delay the development of heart failure. So, and now I invite that next speaker to delivering the discussion about that how to diagnose it. And as Dr. Kohli rightly said, there is a lot of population do come to us with a complaint of breathing difficulty. So how to diagnose and whom to start with the heart failure management? Please start.
So we have to Dr. Viveka.
Dr. Vinesh, who is a head of cardiac sciences at Rainbow Hospital in Agra, he'll be delivering his talk. So can you share your slides, Dr. Vinesh Jain? So I feel happy when he is struggling with technical things, because he is one of the most technically astute person. He would have helped me many times to load my slides and all. So what do Dr. Vinesh Jain?
Thank you, sir. Thank you, Dr. Viveka, for having me here and for your kind words. The topic that I will be discussing today is heart failure diagnostic tools and role of biomarkers. This is a huge topic. Going to the paucity of time, I'll just go into the very basics of it and most important parts of it. Well, heart failure is a clinical syndrome with typical symptoms, signs, and with structural or functional cardiac abnormality, which results in reduced cardiac output or elevated intracardiac pressures at rest or during exercise. Recently, there have been changes in how we categorize heart failure, and what used to be a category of mid-range ejection fraction is now more of heart failure with mildly reduced ejection fraction. This includes patients with ejection fraction of 41 to 49% with signs, symptoms, and or signs of heart failure. It was seen that this category of patient was also improving on medical therapy, and therefore was the need to define it separately. Also, as in the previous talk, it was told that another category of heart failure, improved ejection fraction, has also been included, of patients who initially had ejection fraction below 40%, but now are showing improvement. The two other categories of heart failure, reduced ejection fraction of less than 40%, still stay the same, and the heart failure preserved ejection fraction or HFpEF also remains the same. Those with ejection fraction of more than 50% with objective evidence of cardiac structural functional abnormalities. So what are the diagnostic tools? So for any diagnosis, the most important tool that we have is the history and the signs and symptoms. So these, I'm sure all of us are well acquainted with these typical symptoms and even the less typical symptoms of heart failure and the signs as well. But if we look at the most common symptoms that were reported, or the signs that were reported, were dyspnea, edema, cough, and orthopnea. So this is something which everyone has to go through. Good history taking is most important. But let us see what else is recommended in this category. So basically, various investigations that are to be done in patients with suspected chronic heart failure Obviously, a 12-lead ECG and a transthoracic echo is a must. A transthoracic echo it shows the ejection fraction, and as I told you, that heart failure is characterized on the basis of ejection fraction. But also, as in the previous talk by Dr. Sawhney, and showed the role of GLS and diastolic volumes and systolic volumes. That is also important. Also, nowadays, at places where echo is not available, or even where it is available, the role of biomarkers is very important. It's a class 1 indication for all suspected patients of chronic heart failure and patients who are presenting with dyspnea in the ED. I'll be talking about biomarkers later on in my talk. Chest X-ray is again a very important marker in tests for suspected heart failure patients. Also, routine blood testings for comorbidities, including full blood count, renal function tests, electrolytes, thyroid, sugar tests, iron, lipids, and all are important. For certain specialized patients, some selected patients, some diagnostic tests like the cardiac MRI. So where the echo windows are not very clear, assessment of myocardial function can be done with the cardiac MRI. Also, patients who have some where we want to characterize the myocardial tissue, like infiltrative diseases, amyloid, sarcoid, or myocarditis, LV non-impaction. Cardiac MRI is a very important tool. For ischemic versus non-ischemic, late gadolinium enhancement is also considered a good option. But these are tests which are, as I told, have to be done under these situations, not in all cases. Also, invasive angiography. So invasive angiography is to be done in patients as a class 1 indications where patients have angina despite therapy or symptomatic ventricular arrhythmias. Earlier, the indication of doing it in patients who didn't have angina but had presence of ischemia in non-invasive stress tests was a class 2A indication. Now it has been demoted to class 2B. So clearly, angiography is recommended where there's a potential for revascularization with angina despite therapy or symptomatic ventricular arrhythmias. Another test which is important is the CT coronary angiography. So CT coronary angiography typically would be done in patients to rule out coronary artery stenosis with a low to intermediate pretest probability of CAD. Now this has been promoted from a 2B indication to 2A indication. And other non-invasive stress imaging tests like stress echo, SPECT, PET, or CMR can be considered for assessment of ischemia and viability, where we consider that these patients may get help from coronary revascularization. Cardiopulmonary exercise testing, while this is mainly for transplantation and MCS patients, but it is important where we have to identify the cause of unexplained dyspnea or exercise intolerance is there. One needs to find out the answers. Now, right heart catheterization is not something that you'll do routinely in diagnosis, but in patients where the cause is thought to be constrictive pericarditis or restrictive cardiomyopathy, congenital heart disease, or high output states is a 2A indication. Also, for some cases of HFpEF, it is found out that right heart catheterization could give us some more information. And wherever a patient has pulmonary hypertension, this can be performed to see its reversibility before we go for any structural heart correction. Biopsy, whenever there is a rapidly progressive state of heart failure and no cause can be ascertained, and it feels that maybe a disease which can be diagnosed on biopsy, then it's a 2A indication. Some changes have been made in the recent guidelines regarding the diagnosis, and I have already alluded to them during my talk. One is about invasive angiography being class 1 for angina and for symptomatic ventricular arrhythmias, and for those with positive non-invasive stress tests as being class 2B only. CT angio again promoted up the ladder to 2A for low to intermediate probability, and right heart catheterization pulmonary hypertension is now demoted to 2B from a 2A. So as far as diagnosis goes, a new diagnostic algorithm for heart failure is proposed now by the ESC, and basically it says patients who have heart failure with risk factors, symptoms and or signs, and an abnormal ECG, you do a biomarker test of NT-proBNP or BNP. If they are normal, then exclude them out of the chain. If they are raised, or if you don't have these markers, then go for an echocardiography. If they are abnormal, then this is a heart failure case. And in those heart failure cases, then you do your categorization on the basis of ejection fraction into HFrEF, heart failure mildly reduced ejection fraction, and HFpEF. and then you go ahead and go for the etiology. So there could be various etiologies, as has been discussed by Dr. Abhineet also. And it is with respect to the etiology, there are different investigations that are available, which one can avail. And due to the paucity of time, we can't go into details of these, but all these investigations are available for us to go into the etiology of the disorder. Now, quickly moving on to the second part of my talk, which is about the role of biomarkers in heart failure. And that is really what is the in thing now in management of heart failure. So a biomarker is a characteristic that is objectively measured and evaluated as an indicator of normal biologic process, pathogenic process, or the response to a therapeutic intervention. So what this really means is that we need biomarkers to establish a diagnosis, to risk stratify, and to monitor our therapy over a course of time. So heart failure has a plethora of markers that are available to us, which show different stages of or different parts of the pathophysiology of heart failure. And these could include markers related to oxidative stress or cellular remodeling or myocardial injury, myocardial stress, inflammation, and neurohormones. The list goes on. So we have to weed out which markers are the most important for us right now for heart failure patients. So current clinical guidelines for diagnosis, treatment, and prevention of heart failure recommend biomarkers, predominantly the natriuretic peptides, cardiac troponins, and the SST2 marker for these purposes. So heart failure is a complex syndrome and has to be is often manifest in circulation as biomarkers, and monitoring them can help us in diagnosing and prognosticating the patients and deciding on the treatment strategies, how useful they are. Different markers at different levels. NT-proBNP, BNP can be helpful for at preventive stage. For diagnosis, NT-proBNP, BNP are useful. And then for risk stratification and prognosis, we can add on markers like the galectin, SST2, and the high sensitive troponins. So the most important in this are the natriuretic peptides. And these are really the gold standard biomarkers against which other biomarkers are nowadays compared. Elevated natriuretic peptides support a working diagnosis of heart failure. So to identify which require further investigations, importantly, and this is the most important part, that those people who have normal natriuretic peptide levels are virtually can be taken out of this, virtually but not totally, can be taken out of this heart failure listing. So NT-proBNP has a strong backing by various agencies. The ESC and the ACC both recommend that any patient presenting with this acute dyspnea and suspected heart failure, it's a class 1 indication to perform a NT-proBNP or BNP test to make a diagnosis. Also, it is also useful for prognosis and disease severity estimation in chronic heart failure. It's a class 1 indication. So it is backed by a lot of data and recommendations. As far as the Indian data is concerned, so in the non-acute setting, the levels that have been taken as cutoff for BNP and NT-proBNP are more than 500 and more than 1,000 respectively. More importantly, like I stressed previously, patients with normal plasma natriuretic peptide concentrations are unlikely to have heart failure, and that is a more important part of this. So it is a prognostic marker also. It helps us in diagnosis, but helps in prognosis also. And so 5 times increased risk of mortality or 14 times increased risk of hospital admission has been seen in patients with heart failure with elevated NT-proBNP levels. So it's a strong predictor of adverse outcomes. And therefore, it has a role in diagnosis, prognosis, as well as to prevent new further development of LV dysfunction, how to weed out the cases who are at risk of heart failure. And accordingly, it has got recommendations from different agencies. The other cardiac biomarkers that are important are the SST2 and the high sensitive troponin test. Now, SST2 basically is released by cardiac fibroblasts and cardiac myocytes, and it is released under biomechanical strain. This basically has a role in reducing fibrosis, reducing hypertrophy, preserving ventricular function. In cases of heart failure, the levels of this increases, and this is important not only prognostic, not only diagnostic, but also prognostic value. More so the prognostic part, because it has been seen that in patients who have high NT-proBNP levels, definitely the prognosis is bad. But among patients who have high anti-proBNP levels, who had the highest number of mortalities and the highest hospitalization and rehospitalization rates. So therefore, it has a important role in prognosis of heart failure. Now, cardiac troponins, as we know, in the ischemia pathway, they are very important, but in heart failure also, they are important because they can be released in response to increased myocardial oxygen demand. Why would that happen? That would happen obviously wall stress, dilated left ventricular chamber size, elevated pressures in cardiac chambers, and others like this. So among high sensitive cardiac troponins, we see that among 50% of patients with advanced CHF without ischemia would have high troponin levels. And patients presenting with acute heart failure in the absence of ischemia, troponin levels may be high due to ongoing inflammation and myocyte injury. So these are also very important markers to prognosticate and to risk stratify patients at admission and discharge. In this study has shown that pre-discharge troponin levels, if they are high, have a significantly higher 90-day mortality and readmission. So in the reliance in the high troponin T levels are a very important indicator and indicate first outcomes with a strong association with 180-day cardiovascular mortality. So high sensitive troponin T can quantify myocyte injury. Soluble Sp2 reflects ventricular wall stress. Both of these are robust prognostic markers of heart failure. And as I said previously, they can show up to a 65% increase in risk of cardiovascular death or heart failure hospitalization, or 51% increase in cardiovascular mortality in HFrEF patients. So they have a role of class 1 indication in risk stratification for high sensitive troponins, and for prognostication, SST2 has a class 1 indication for the same purpose. One more important point as far as biomarkers are concerned is that these biomarkers, they give us an independent value about the risks and the prognosis, but they have additive value as well. So if we start seeing all the three biomarkers, then the lowest risk of hospitalization or mortality is in those which have none of these raised. And the ones who have all three raised have the highest mortality and admission rates. Among them, then there could be different combinations of neuropeptides of troponin T and SST2, in which SST2 seems to have a very high prognostic value, as I described earlier. So various guidelines have shown that anti-BNP and BNP are good for diagnosis, prognosis, and for screening, while troponins, high sensitive troponins, have a good prognostic value and have a pre-discharge value, also have a very high indication about long-term result. SST2 and galectin-3 have prognostic value also. Thank you. Thank you so much.
Thank you, Dr. Jain. You have beautifully outlined the role of biomarkers in differentiating heart failure from other non-cardiac causes of breathlessness and its role in prognosis. And also, I think it can tell you the timing of the discharge of the patient, when we should discharge the patient. Now, I think we should.
Yes, sir.
Yes. I think Dr. Tripathi has not come up. Dr. Tripathi, to introduce the next speaker. Dr. Tripathi, unmute.
I think he's not able to.
Dr. Naresh Goyal then will introduce the last speaker. Dr. Naresh Goyal.
First, I would like to thank you to Dr. Dharmesh for nicely defining the role of different biomarkers. And these are really important biomarkers where we can diagnose, and not only diagnose, also help in the treatment of these things. Sorry, Dr. Vineet Jain. Now I request Dr. Dharmendra Jain for discussing the next topic, the sudden cardiac death, which is the most dreaded complication, side effect of the heart failure. That's why we are discussing the heart failure topic nowadays, and the sudden cardiac death is the most important aspect of it. So I request Dr. Dharmesh Jain to start his topic.
Thank you, sir, for giving me opportunity and nice introduction. And I thanks Dr. Viveka sir for giving me opportunity in his all the endeavors. I am there. He is my mentor, and he is jack of all and my all the taken things. So I will start with the. Am I audible?
Yeah, we can hear you. Can't see your slides. Please upload the slides.
Okay, I will share it.
Yes, we can see the slides.
Okay, so this is a very important topic of sudden cardiac death and news. What we need to know further. So recently we have seen that Siddharth Shukla and other celebrities, they have the deaths from cardiac arrest, and the similar thing happens in the general population also. So the 10% of all deaths in India is due to sudden death, sudden cardiac arrest. The new knowledge came from the China and India according to the research that was conducted, improved SCA study conducted over 4,000 patients that says that we can identify the people and can help to save them using the ICD device. So the options are there for safety also. So sudden cardiac death is used to describe cardiac arrest with the cessation of cardiac function, whether or no resuscitation or spontaneous reversion occurs. So cessation of cardiac function is cardiac arrest, and patients who do not die after cardiac arrest should be said to have experienced aborted SCD. So who are survived, they are having aborted SCD. By AHA also there is definition for sudden cardiac death that describes the unexpected natural death from a cardiac cause within a short time period, generally less than 1 hour from onset of symptoms in a person without any prior condition that will appear fatal. So epidemiology, sudden cardiac arrest is more likely to occur in males between ages 66 to 68, and early morning and late afternoon shows the circadian peaks of death in the morning and late noon. And most of the causes of sudden death are of cardiac origin in 85% of cases, and SCD account for 50% of death in cardiovascular disease patients. And coronary artery that contribute to majority of sudden cardiac death over 90% of cases. We can see the SCD incidence per lakh, and India stands around 40 deaths per lakh. So it is comparable, and some of the countries are recently having a increase in the incidence, like US or New Zealand or Australia. Often occurs without any warning. So SCD and sign and symptoms are immediate and drastic and include loss of consciousness, sudden collapse, pulseless, and lack of breathing. Other symptoms can be chest pain, dyspnea, fatigue, palpitation, and syncope. So time references we see in sudden cardiac death is it starts with the prodromes, new or worsening cardiac symptoms, chest pain, palpitation, dyspnea, fatigability days or months ahead. And then there is an onset of terminal event at abrupt change in clinical status. It may be arrhythmia, hypotension, chest pain, dyspnea, or lightheadedness. And then cardiac arrest, sudden collapse, loss of effective circulation, and loss of consciousness. This may take up to 1 hour. And then biological death if there is a failure to resuscitation or failure of electrical, mechanical, or CNS function after initial resuscitation. So it is a matter of minutes, or it may survive for weeks. So risk factors are previous cardiac arrest, previous MI or CAD, previous history of ventricular arrhythmias, poor LV function, of course, heart failure, very important, and family history of SCD, HOCM, or long QT syndrome, etc. So primary pathology, if we see it according to patient age, from birth to 13 years, a congenital abnormality like TOF, 14 to 34 years, it may be HCM, ARVD, or congenital coronary anomaly, or channelopathies, myocarditis, WPW, and Marfan's. And over 35 years, it's coronary artery disease. The vast majority of SCD occurs due to ventricular arrhythmias, VT or VF, that accounts majority of episodes. This almost always occurs in setting of underlying myocardial disease. More than 80% SCD occurs in individuals with coronary artery disease. So we can see the one example that at 6 to AM there is a onset of arrhythmia, and at 6:11 a.m. it's asystole. So total 9 minutes. And VF, there is a complete absence of properly formed QRS complex, no obvious P waves, and recent onset of arrhythmia is suggested by course morphology. So we can see the biological model where the one PVC electrogenic theory is PVC, which induces the VPVF, and in the baseline there may be structural changes like MI, acute, healed, or invisible, or hypertrophy, secondary or primary, or myopathies, dilatation, fibrosis, infiltration, or structural electrical abnormality. So these may be structural changes or functional changes like transient alteration in the blood flow, vasomotor dynamics, acute ischemia, reperfusion after ischemia, systemic factor like hemodynamic failure, hypoxemia, acidosis, electrolyte imbalance, neurophysiological alterations like transmitters, receptor central influences, toxic effects like pro-arrhythmic drug or cardiac toxicity all lead to arrhythmia, electrogenic, VT or VF, ultimately causing the sudden cardiac death. So what tests we should do in a sudden cardiac arrest patient? We can do ECG for the purpose of diagnosis of ISD, MI, or inherited channelopathies. Echo we can do that can show the signs of heart failure, cardiomyopathy, valvular disease, and congenital disease. We can do the coronary angiogram for evidence of CAD or congenital coronary anomaly or coronary spasm. Exercise test can illustrate the ischemic heart disease, of course, and the long QT syndrome or CPVT. Then electrophysiology detects the suspected arrhythmia. Troponin can provide the Brugada syndrome regardless of findings of initial ECG. Cardiac CMR is also helpful to show the ARVC, sarcoidosis, myocarditis, or myocardial injury from coronary spasm. Genetic testing we can do if cardiomyopathy or Brugada or CPVT or long QT are found. Cardiac biopsy can also be considered. So these are the tests which can help in SCD cases. And electrocardiogram markers like microvolt, P-wave alterance, T-peak, QT end interval, QRS fragmentation, or QRS duration can be seen. The treatment part, in a case of SCD, we can correct the ischemia by revascularization with beta blockers. We can prevent the plaque rupture by statin, ACE inhibitor, or aspirin, and stabilizing the autonomic balance by beta blocker, ACE inhibitor, or improving the pump function by ACE inhibitor, beta blocker, or now we have Arnia also in our hand. Prevention of arrhythmias, beta blocker or amiodarone, or treatment of arrhythmias by ICD or AEDs, and prevent ventricular remodeling and collagen formation by aldosterone receptor blockade. So the ICD is, we all know that it has a constant monitoring, and when they detects it, the arrhythmia gives the biphasic shock. So this is ICD evolution, and we have very small size ICDs available now. And we can see the, currently we have the ICD, or if the arrest is there without ICDs, and then it is resuscitation by AED and by the help of, and finally comprehensive care. But in future we can have a curated database and cloud-based database and a smart analytics that can prevent the sudden cardiac arrest, and we can understand and predict the real-time biometrics, and app initiations can be there, and response can be there by cloud coordinated resuscitation. So this is the future of maintenance of cardiac arrest, where we can take the help of the latest technology. And these are the guidelines of ACC/AHA, which clearly shows that if EF is less than 35% or less, and due to ischemic heart disease, and at least 40 days post MI, or at least 90 days post revascularization, and patient is still in NYHA 2 or 3, despite GDMT, the ICD is recommended if meaningful survival of greater than 1 year is expected. So this is class 1A indication in a patient 40 days post MI or 90 days post revascularization if EF is less than or equal to 35% and more than 1 year life expectancy. Class 1A indication for ICD. In patient EF 30% or less due to ISD, and less than 40 days post MI, or at least 40 days post MI, or at least 90 days post revascularization, and NYHA class 1 despite GDMT, ICD recommended. So if the patient is class 1, then EF should be a little more less, like 30% or less, and if it is class 2 or 3 NYHA heart failure, then EF 35% or less. So these are indications for ICD, and for the medical therapy guideline directed in patient with heart failure with reduced infection EF less than or equal to 40. we can give beta blocker, MRA, ACE inhibitor, ARB, or ARNI, which is recommended to reduce the sudden cardiac death and all-cause mortality. So this is class 1 A indication, and the sacubitril/valsartan demonstrated a reduction in sudden death and cardiac mortality compared with ACE inhibitor. So this is head-to-head comparison is available. And similarly, ESC guidelines also recommend the ICD to reduce the sudden death and all-cause mortality in patient with symptomatic heart failure class 2 to 3, EF less than 35, despite 3 months of OMT, provided they are expected to survive substantially longer than 1 year with good functional status, and they have ISD class 1A indication, and in DCM it is class 1B indication. So, so the recommendation for medical therapy, the beta blocker, MRA, and sacubitril/valsartan reduces the risk of sudden death, and it is recommended with heart failure with reduced ejection fraction and ventricular arrhythmias, class 1A indication. And here we can again emphasize that ARNI is demonstrating the reduction of sudden death and cardiac mortality compared with ACE inhibitor. So risk of sudden death, we can see that it remains despite guideline-driven therapy like ICDs. We can see that in 320 patients, review of 320 patient deaths during trial of ICD, the most common mechanism of sudden death was VTVF, even in the patient he is on ICD. So to summarize, in heart failure, heart failure is a progressive disease whereby cardiac structural and functional deterioration occurs even during the early stage of the disease. Stability of symptoms in heart failure should not be mistaken for indication of stability of underlying disease. Patients who are mildly symptomatic class 2 and deemed to be clinically stable remain at high risk of sudden death. Class 2 patients are high risk of sudden death still. Guidelines recommend both mechanical and pharmacological therapy to reduce the sudden death in patients with heart failure with reduced ejection fraction. Despite their demonstrated clinical benefits, some heart failure patients with ICD still die suddenly. So we need something more. So the medical therapy is there, especially ARNI they have introduced. Therefore, pharmacological therapy should be optimized in patients with and without ICD to further reduce the risk of sudden death. So take home message, friends, 15 to 20% of all deaths are sudden cardiac deaths. And etiology wise, it can be CAD, cardiomyopathy or channelopathy, and up to half of the patient report no prior symptoms. And evaluation, we can do clinical history, physical exam, ECG, echo, Holter, genetic testing, and electrophysiology testing. And for prevention, we can use beta blocker, amiodarone, ICDs, coronary revascularization, and ARB or ARNI, ACE inhibitor, and future directions are transvenous versus subcutaneous ICD, extracorporeal membrane oxygenation, or target temperature management for these sudden cardiac death patients survivors. Thank you very much.
So thank you, Dr. Dharmendra, for wonderful talk on the sudden cardiac arrest. So I think in the interest of time, we will have to move on to next session. So I must thank all the speakers and the chairpersons. At the end of the second session, we will have brief question answer also, because we have received a lot of questions also from the audience. So may I invite the chairperson for the next talk, Dr. S.P. Singh. Dr. S.P. Singh is head of medicine at Safdarjung Hospital and very renowned physician and cardiologist also. And our panelist for today, Dr. S.K. Chauhan, who is again very renowned physician, cardiologist at in South Delhi and president of PFI, that is Physician Forum of India. And Dr. P.K. Gupta, again, he's a very famous physician and cardiologist in South Delhi. So I would request Dr. S.P. Singh sir to introduce our next speakers and take the proceedings further. So this is very important session about what the guidelines says and what are the guideline directed therapy. In fact, one of the talk has already been delivered by Dr. J.P.S. Sahni in the previous session due to his time constraint. Over to Dr. S.P. Singh.
Thank you, Dr. Viveka. Thank you very much. And thank you once again for organizing such a wonderful topic. Heart failure is a very important and serious ailment, and it is underdiagnosed by most of us. So without wasting time, so we have in this session 3 speakers. So Dr. Anshul Kumar Jain would be talking on guidelines on the heart failure. And Dr. Jain is currently HOD Department of Cardiology at Sri Aggrastan International Hospital, Rohini. He has prolific experience in the field of cardiology, along with well-known scientific publications. He has been an active participant as key opinion leader at various national and international organizations. He has been awarded with Sharma Award for Best Care Presentation at India Live 2013, and he has received invitation as faculty from various national and international organizations. So over to Dr. Anshul Kumar Jain.
Dr. Viveka, really thanks, long time. And Dr. S. Singh, many thanks for a very kind introduction. I can see luminaries sitting in this dais, Dr. J.C. Mohan, Dr. Hajra, my senior, Dr. Pandey, Dr. Bhatt. Good to see you all on this Sunday morning. Thanks, Dr. Viveka, for this. Now, I have been entrusted with a very simple task because most of the previous speakers have actually summarized most of what I'm going to say. So I'll cut down on, save on my time and everybody's time with what I'm going to say. So what are the 2021 heart failure guidelines? What's new about them? So I have tried to combine the guidelines from the American College of Cardiology and European Society of Cardiology and see. So as Dr. Ajay Pandey said, that in India, the current incidence of heart failure varies between 1.3 to 23 million. And most of our patients are young. They have frequent admissions and lose life in their productive years of their life. So what is new about the diagnostic criteria or definitions of heart failure? So we have been dividing the heart failure into HFrEF, that is heart failure with reduced ejection fraction, heart failure with mid-range ejection fraction, and heart failure with preserved ejection fraction. So the latest is that the mid-range ejection fraction has been relabeled as mildly reduced ejection fraction. The idea is to say that the patients who are in mildly reduced ejection fraction follow the same pathology of patients who have reduced ejection fraction eventually. Therefore, the therapies which are earmarked for heart failure with reduced ejection fraction would be effective in the patients who have mildly reduced ejection fraction, although the pathology of preserved ejection fraction is likely to be different. So that is the first change for all of us. Second is that a distinct clinical entity of advanced heart failure has been mentioned. And we have been studying the American College of Cardiology stages of heart failure as ABCD. So this corresponds to stage D. So what is new about advanced heart failure is persistent symptoms despite medical therapy, and they have come out with a criteria for these symptoms. So the following criteria must be present despite optimal medical therapy. First is the severe and persistent symptoms of heart failure, that is NYHA class 3 advanced or 4. Second is at least one of the following cardiac dysfunction should be present, like ejection fraction less than 30%, or isolated right ventricular failure, non-operable severe valvular abnormalities, or congenital abnormality, or persistently high or increasing biomarkers. Thirdly, episodes of pulmonary or systemic congestion requiring high-dose IV diuretics, intermittent inotropes, or vasoactive agents, or presence of arrhythmias causing more than one unplanned visit or hospitalization in past 1 year. Severe impairment of exercise capacity with inability to exercise or low 6-minute walk test. So this is the first time that a specific criteria have been mentioned for advanced heart failure. And these are the patients who would end up with mechanical therapies or with heart transplant eventually. And this is also the first time when cardiac transplant has been given the class 1C, 1B indication for this class of patients. Now, coming to the usual therapeutic algorithms, the patients, almost no more than 30% of Indian patients receive the GDMT, the guideline mandated therapy. It is because of a simple reason that these guidelines were very complex so far. So this time, a very simplified patient-centric approach, which puts the patient in perspective and devices and medicines in the background have been put forth. So 4 pillars of medical therapy have emerged, which are ACE inhibitors or ARNI, beta blockers, mineralocorticoid antagonists, and SGLT2 inhibitors. The loop diuretics have to be used for decongestive therapy. Once you are able to optimize the medical therapy, the device therapy in form of AICDs or CRTDs or cardiac transplant would be considered separately. So coming to the pharmacological treatment indicated in patients with the HFrEF, the ACE inhibitors, beta blockers, MRAs, and SGLT2 along with ARNIs have been given class 1A recommendation to reduce the risk of heart failure, hospitalization, and death alike. In beta blockers, it is carvedilol, metoprolol, and bisoprolol. No, not like nebivolol and others have not been enlisted this time. So you have a clarity which beta blockers to use. Whether to use ACE inhibitors, ARNI, or beta blockers first, which one comes first? Well, the patients who are dry may tolerate beta blocker better. The patients who are wet, they tolerate the ACE inhibitors or the ARNI better. So this is the first time that the SGLT2 inhibitors have been recommended to reduce the risk of heart failure, hospitalization, and death without any equivalence. Other pharmacological treatments, the loop diuretics are recommended in patients with HFrEF with signs of and symptoms of congestion. A point has been highlighted here that if you require more than 80 milligrams of furosemide per day, you should add hydrochlorothiazide or metolazone to achieve better decongestive symptoms specifically. As far as ARBs are concerned, it is recommended to reduce risk of heart failure, hospitalization, and cardiovascular death in symptomatic patients unable to tolerate ACE inhibitors or ARNI. So patients should also receive beta blockers and MRA. What about the ivabradine? Well, the indications remain the same as previously. It is class 2AB or 2BB. What about verisuagot? Yes, this is another new indication based on the Victoria trial. Verisuagot may be considered in patients who have NYHA class 2 to 4, who have had worsening heart failure despite treatment with ACE inhibitors or ARNI, a beta blocker and an MRA to reduce the risk of cardiovascular mortality or heart failure hospitalization. Victoria trial, as we all know, resulted in 10%, a modest reduction in heart failure hospitalization, whereas there was not much change in the cardiovascular mortality. The indications for hydralazine and isosorbide nitrite, as well as digoxin, remains the same as they were previously. What about diabetics? There are specific recommendations that all diabetics must be given SGLT2 inhibitors. Which inhibitors? Canagliflozin, dapagliflozin, EMPA, R2, and sotagliflozin are recommended in patients with diabetes at risk of cardiovascular events to reduce hospitalizations for heart failure, major cardiovascular events, end-stage renal dysfunction, and cardiovascular death, that is class 1A. What about SGLT2 inhibitors like DAPA, empagliflozin, and sotagliflozin are recommended in patients with diabetes and heart failure to reduce hospitalization for heart failure and cardiovascular death. Well, for preserved heart failure, based on the Emperor preserved data, the SGLT2 inhibitors, specifically empagliflozin and dapagliflozin, have been given FDA clearance class 1A for use in patients with heart failure and preserved heart failure. They have not been included in guidelines so far because the results came after the publication of guidelines. The specific indications, recommendations have been given for iron deficiency in heart failure. It is recommended that all patients with heart failure should be periodically screened for anemia and iron deficiency with full blood count, ferritin concentrations, and transferrin saturations. Intravenous iron supplementation with ferric carboxylase should be considered in symptomatic patients with ejection fraction less than 45% and iron deficiency, serum ferritin less than 100 nanograms per ml, or serum ferritin between 200 to 299 nanogram per ml, and TSAT less than 20% to alleviate heart failure symptoms and improve exercise capacity and quality of life. IV iron supplementation with ferric carboxymaltase should be considered in symptomatic HF patients recently hospitalized for heart failure and with ejection fraction less than 50%. The level of indication is class 2AB for this. Now, coming to the devices, a specific phenotypic approach which is individualized to each patient has been clearly highlighted in these guidelines. For implantable cardioverter defibrillator in patients with heart failure with ischemic background, for secondary prevention, it is class 1A. For patients who, as well as for primary prevention in patients who have ejection fraction less than 35%, despite more than 3 months of optimized medical therapy, it's class 1A. For non-ischemic cardiomyopathy, these patients, despite the indication have been toned down to class 2AB. Now, for regarding resynchronization therapy in patients with heart failure who are in sinus rhythm with ejection fraction less than 35%, despite optimal medical therapy, CRT is recommended class 1A for patients whose QRS duration is more than 150 milliseconds. For patients whose QRS duration is between 130 to 149 milliseconds, the CRT may be considered. The level of indication is class 2AB. For patients, CRT may also be considered for symptomatic patients in sinus rhythm with a QRS duration of 150 milliseconds with non-LBB morphology. CRT may be considered in symptomatic patients in heart failure and sinus rhythm with the QRS duration of 133 to 149 milliseconds with non-LBB morphology. Indication is class 2BB. Regarding CRT, now this is interesting that all patients with high-grade complete AV blocks, patients with complete heart block or advanced second-degree AV blocks who require pacing, and the CRT should be considered rather than RV pacing in these patients with reduced ejection fraction, and this includes patients who are in atrial fibrillation. So for the first time, atrial fibrillation has been included as an indication for cardiac resynchronization in patients who have high degree AV block. Patients with ejection fraction less than 35% who have received a conventional pacemaker and who have heart failure despite optimal medical therapy should be considered for upgrade to CRT. This is the level of indication is class 2AB. Third is CRT is not recommended in patients with QRS duration less than 130 milliseconds who do not have indication of pacing due to high degree AV blocks. Now, this one is interesting. The management of atrial fibrillation. Now, this is again the first time that clear-cut instructions and indications and recommendations have been put forth for management of atrial fibrillation in heart failure. So, apart from optimal medical therapy and anticoagulation, which is class 1A, one should rule out the treatment or the triggers of atrial fibrillation. And once these are ruled out, then patients who are hemodynamically unstable with atrial fibrillation should be cardioverted. That's the ECV means electrical cardioversion should be performed. And once the cardioversion has been performed and patient has been converted to sinus rhythm or stabilized, the patient should undergo for the pulmonary venous ablation, which is class 2A now, or amiodarone therapy, which is class 2B. For the patients who were hemodynamically stable with atrial fibrillation, rate control should be attempted with beta blockers, digoxin, or amiodarone. And once the patient has been stabilized, you could go for pulmonary venous ablation, amiodarone, or electrical cardioversion to sinus rhythm. The patients may be held up in follow-up closely. Now, for those patients who do not respond to rate control measures or rhythm control measures, AV nodal ablation with pacemaker implantation may be considered. Level of evidence class 2B. Now, coming to secondary mitral regurgitation. Now, in these guidelines, specific indications and recommendations have been put forth for patients with aortic stenosis, tricuspid regurgitation, and mitral regurgitation. Definitely, our interest is more on the secondary mitral regurgitation. So the guidelines say very clearly said for that the patients who have secondary mitral regurgitation, a heart team approach should be adapted. For the patients who have an element of coronary artery disease, who are at very high risk for surgical intervention, and percutaneous coronary revascularization should be performed, and then reassess for symptoms and level of degree of mitral regurgitation. Otherwise, if the patient is at moderate risk, then coronary artery bypass surgery with mitral valve surgery should be performed. Now, for those patients who are not candidates for coronary revascularization, optimization of medical therapy should be performed, and CRT as per indication should be performed. Mitral valve therapies should be considered only after implantation of CRT-D or CRT-P. The heart team should approach. If the patient with non-ischemic cardiomyopathy is a low-risk candidate, consider surgery for mitral valve. If the patient is at high risk, go for the COAPT criteria. We all know the COAPT criteria. If the patient fits into one of these COAPT criteria, go ahead with end-to-end mitral valve repair, mitral clip, etc. If the patient does not fit into the COAPT criteria, in those cases, we need to reevaluate the patient and consider these therapies as the level of indication would be class 2B then. So to summarize, what are the key changes to heart failure treatment in 2021? There is a new class 1 recommendation therapy for HFrEF vis-a-vis SGLT2 inhibitors, specifically dapagliflozin and empagliflozin. Dr. J.C. Mohan would be taking this up in details. 4 key drug therapies should be initiated as quickly and safely as possible. SGLT2 inhibitors get FDA clearance for HFpEF management. Importance of patient-centric tailored management. Primary prevention ICD in non-ischemic cardiomyopathy has been toned down to class 2A now, and emphasis on broad LBB in selecting patients for CRT. Thank you.
You are on mute, Dr. S.P. Singh.
Okay, am I audible now?
Yeah.
So we have very dynamic next speaker with us today, Dr. Prakash Kumar Hazra. He is head of the interventional cardiology, AMRI Dhakuria Hospital, Kolkata, and he is an alumni of PGI Chandigarh. And he has many firsts to his achievements. He is first in the Eastern India to implant artificial heart, first cardiologist to implant wireless pacemaker in Eastern region of the country, and he is the first cardiologist in Eastern India to use shockwave therapy for complete heart block. He is the first cardiologist to implant fully MRI-compatible wireless defibrillator in India, and he is the first cardiologist to implant subcutaneous ICD in the Eastern region of the country. He is the first to do non-surgical heart valve repair TAVI in Eastern India, and he is the first cardiologist to do LAA closure device for stroke management. He is member CSI and FACC. So over to Dr. Prakash Kumar Hazra.
Thank you, sir. Thank you, Dr. Vivek Kumar, for inviting me. You know, the heart failure is a disease of the precedence. And today I'll be discussing a de novo heart failure with reduced ejection fractions. Is definitely a little different from the worsening heart failure with known ejection fractions in the background, on good medical therapy in the background, ischemic or non-ischemic. There's a lot of evidence with pre-existing heart failure, deteriorating heart failure in our medical science today. Now, you have to understand that ejection fraction is just an arbitrary. We have certain trials, less than 25% only one, less than 30% only one, and less than 35%, most of the trial, Rails, Series, Miracle. Some of these are very new, marked in red, Galactic HS, Barostim for your carotid body stimulations, AF, non-AF, less than 35%. And we have Arnitral paradigm, less than 35%. We have many other drugs which have been tested in this group of people. Then we come down to 40, above 40. We have many trials which has included less than 40, above 40, less than 45, above 45. So Victoria, these are the new trial. Iron is definitely one of the trial which is discussed recently in many forums. We have new drugs like your captive to come in the next month, and we have very so good. And we have also know that many trials where the ejection fraction was totally, completely unknown. And one of them is consensus, the second is empiric. Now, in this journey of heart failure, the road ahead in heart failure, everything has been discussed so far, starting from a vaccine, fibrillations, and it also differs from patient to patient. If you have amyloidosis with preserved ejection fractions, it's a very costly drug. If you have a patient who has not responded to good medical therapy, we can always think for clips, Barostim, and these are the devices which will work in mid-range ejection fractions and along with atrial fibrillations. Also, there is a new kid in the town, the LBB zone pacing, his bundle pacing, influenza vaccines, rate control. So these are very important to understand the building block of any heart failure. Is beta blocker, SGLT2, kappa and EMPA, ARNI, and MRA. Now, this picture is going to change very fast if you have this phenylaron in your armamentarium. Now, as I understand, all these are these MRA SGLT2 less than 40, above 45, or less than 45, starts with loop diuretics. They may not be born equal, but they have equal rights to be the first line of therapy. And we always talk about ACE inhibitor therapy just because it's a historical construct, and they came early in the trial, early in our history, in our knowledge. And if you have heart failure, the heart doesn't understand whether to stimulate the first soldier, the RAS system, to protect the people from death, or your sympathetic system. So either one is activated, all are activated, or none are activated. So you need all of these drugs at the very first line of drug. And this is not a step care anymore, and it is a circle. You can put your money anywhere, and your drug will be a winner. Now you have the second line of defense, which will be discussed further. And we also go for newer therapy like mitochondria transplant. We take the mitochondria from one heart, mitochondrial cytopathy, and these people also, especially in the kids, where device therapy is very, very difficult. So this mitochondrial transplant is also a promise. Now, its age-old ACE inhibitor should take rest because the newer kid, SGLT2 or RD, has become taller than the pre-existing drug therapy. I understand there are only two types of heart failure, either RAPE or non-RAPE. The value for money of any drugs is much more if you have reduced ejection fractions, but definitely worth trying in a group of people where there is no hope, that is heart failure with preserved ejection fractions. In spite of ARNI is the best drug to treat in the randomized clinical trial, the usage of ARNI is not that great. If they have used in 100% of cases, we had little difficulty in understanding this trial, or this trial should be redesigned like EMPA-RATE, Galactic, Soloist, Victory, and NAPA. The penetration was poor. We also know that the special MRA, the cardiac MRA, phenylaron, they're much more concentrated in the heart. So the ratio between the difference between the replacement of lepidolol with phenylaron makes sense because the concentration of these receptors, antagonist phenylaron, is almost like the phenylaron is 170%, 70% higher than eplerenone. So that makes sense. There is a cardiac MRA, and the nephro inhibition is 319%. So if you have a nephropathy and heart failure, it makes sense that you can choose eplerenone. But if you have pure cardiac failure, you can choose phenylaron. So these are the few drugs which can be prescribed without knowing the ejection fraction: ARNI, SGLT2, diuretics, and iron. And de novo heart failure is a growing challenge, and many of these patients are seen in our day-to-day practice. And here she is the lady, my Mithali, Indian lady. Just because you're Indian and just because you are born in Asia, there is air pollution, stress factor, and the 10 years minus, you have the onset of heart failure. So if she was an American, the 63, this is 53, female, the female are special group of people because they have a smaller heart and larger ejection fractions, and they do respond better to pharmacotherapy. Since he's diabetic, we have to understand they also suffer from nephro, like albuminuria, they have falling GFR, and she was rushed to the hospital. So there is no information what she was having previously. So there is no documentation of ejection fraction in the past. So if you do the echocardiogram now, if you see ejection fraction certain numbers like 30%, you do not know whether it's a fall from 45 to 30 or is a fall from 55 to 30, or yesterday his heart ejection fraction was normal. Now he has developed a viral myocarditis or myocardial infarctions. So this devastating presentation we see in day-to-day life. And since these are very common symptoms, we know what are the symptoms they present with. Anyway, her ejection fraction was very low, and this is the first time we're coming to know that she is in sinus rhythm. So was investigated, and investigated to be found that she's got narrow QRS. So the many options are limited in narrow QRS on ECG, but there are much better options that are left in sinus rhythm. Creatinine, again, is forgiving for any cardiac patients. If you have these renal dysfunctions, it will be reflected much earlier with your albuminuria and GFR than creatinine. So creatinine helps us to evaluate further by like doing angiogram where contrast is an issue. GFR is falling. So you have to protect the kidney, and he or she is having G3A status and ACR is 500. So that means he's quite heavily albuminuric, and potassium is forgiving. Now, potassium therapy, if you start a modern drug therapy like eplerenone or spironolactone along with ARNI, if you have a falling GFR, I'm sure one day she will face hyperkalemia. Now, the incidence of hyperkalemia can be reduced to some extent if you replace ACE inhibitor on the very first day, and if you start your journey with ARNI on the very first day, the future hyperkalemia can be reduced. Hyperkalemia will happen, but if you start your journey with finerenone plus SGLT2 plus ARNI, perhaps it will be delayed. If you start your journey with spironolactone and other drugs, the hyperkalemia incidence will be more, and it will be earlier. See, heart proBNP was in thousands. You do not need to measure these drugs if you have a congestive cardiac failure with S3, JVP raised, and crepitations. So basic question in diabetic heart failure with de novo status, that whether basic question is reduced or non-reduced, GFR reduced or preserved, albumin or not, drug name or not, previous lab investigation is a falling figures like falling EF or falling GFR or rise from the fall. A for non-A, QRS, iron status low or high, ischemic or non-ischemic is very important because many of these patients can have in India a diabetes with multivascular disease, multivessel disease. So we have to put them for revasculations. Vaccinated or not vaccinated, there is a history of hyperkalemia in the past or not. So whatever it may be, the mortality rate in these patients are very high. Hospital outcome, if you start on the very first day with ARNI and SGLT2 and beta blocker, diabetics, IRX, vaccinations, even very sugar, can prevent the further hospitalizations. The risk of readmission can be reduced if you use wisely ARNI, and if you replace the age-old ACE inhibitor with ARNI on the very first day. Very limited data in hospitalized heart failure patients. There is not a single trial of ACE inhibitor which was tested in hospitalized patients. And we still give this ACE inhibitor. So why we waste time 1 month? We can start ARNI on the very first day, and she was put on this guideline-directed medical therapy. And there are many, many guidelines which can back you up, and definitely I'm going to back you up. So quality of life is important, friends. So what is the ultimately in India, we also want to know how much it gives at what time. So if you start your journey or give these 4 fabulous drugs in the very first week, you gain certain years of life. So it adds years to your life and life to your years. So definitely your quality of life improves, you gain your life. And these are basically additive, complementary. There is no competition between those. And if these 4 drugs or 5 drugs or 6 drugs can definitely increase your lifespan. Now, since she is a female, there is a lot of difference in male and female. Men are from Mars and women are from Venus. But on the land, they are little different. They have lower lifetime risk of sudden cardiac death. They have more non-ischemic cause, more likely present with EMD asystole, less fibrosis, often normal biopsy. They have heart failure onset high ejection fractions, less VT, longer QT intorsities, more survivors of sudden cardiac death syndrome. They are INOCAS, more responder to CRT, and we know they are separated by 5% ejection fractions. Now we know that these drugs, if you start early, it starts giving this blessing from the very first day. The insulin's volume, biomarker reductions, and should be started with higher dose. And if you start with higher dose, you start getting this blessing from the very first day, so it's not delayed. The difference between men and the animal is basically inflammations. So there are a lot of drugs which can prevent inflammation. So in this video, if you see these mice, if you upload their LED, they're active on the very first day, and they're active also at 56 days. So 56 days of my life is equal to 10 years of human. So remodeling occurs very fast in human being, and you get dyspnea. This lady will get dyspnea on the very first day of MI myocarditis. And this is absolutely due to inflammations and cholesterol. These mice do not have cholesterol and they do not have inflammations. So the rapid remodeling, so these mice are very active on 56 days of chronic heart failure, but ultimately human being, we have to prevent this remodeling by early institution of therapy. So these are the mechanisms of RNA which can prevent remodeling, the volumetrics, the LA, left atrial volume, the ratio can be reduced. So how many questions I would ask? Only two. The classical congestive cardiac failure with classical signs and symptoms, JBB raised grapes, etc. Yes, start with these drugs. First drugs should be diuretics. Then if you do not have all these things, then rule out other causes. Ejection fraction reclassify if you really want to justify the DDMT. But you have to understand that if you have a falling ejection fractions, your neuroendocrine system is very, very active. If you have a rising ejection fraction, the neuroendocrine system is less active. So the value for money and the return on investment on ejection fractions comes down if your ejection fraction improves, but you should continue to give this therapy lifelong. So there are certain drugs like SGLT2, Verisogard, they are not dependent on ejection fractions and they are not neuroendocrine medicines. So this polypharmacy is much more on the other side. So dose is important, and the need for ICD or that you can delay this costly device by introducing RNA. So these frequent flyers will be restricted, and they come, ultimately they will come, they will die in the hospital. Nobody can prevent death, only we can delay death. So this life cycle of heart failure can always be reversed or can be delayed. So what goes up can definitely come down with your therapy. So to summarize, friends, this de novo therapy is different, and this is different from other therapy, but ultimately it combines. It's just a matter of time. Today is de novo, tomorrow is a classical heart failure. So one day, instead of thinking one day, your day one activity should start with RB, beta blocker, ACU2021, and other therapy. And don't forget the vaccinations. Thank you, Dr. Kumara, for inviting me.
Thank you, Dr. Hajra, for a wonderful talk. And I think that was really great. Can you invite next speaker? And at the end, we'll have talks. I'll request Dr. Chauhan to introduce our next speaker who needs no introduction in true sense, Dr. J.C. Mohan. Dr. Chauhan, please introduce Dr. Mohan.
Right. Thank you, Dr. Viveka, sir, for inviting me to this important digital discussion on congestive heart failure. Am I audible, sir? Dr. Viveka, sir? Am I audible?
Yeah, we can hear. Yes.
Yeah, so friends, we have now an important discussion on the role of SGLT2 inhibitors in heart failure. As you are aware, there has been now a lot of data on SGLT2 inhibitors, earlier on reduced ejection fraction from EMPA-REG, and now we have good data by the HFrEF study in which there has been a role for SGLT2 inhibitors even in those with preserved ejection fraction. And to deliver his talk, I invite Dr. J.C. Mohan, sir, who is currently chairman of Institute of Heart and Vascular Disorders at Jaipur Golden Hospital in New Delhi. Sir has earlier served as director of Fortis Hospital, Shalimar Bagh, Sundarlal Jain Hospital, Metro Heart Hospital, and Saroj Hospitals. Before his foray into private practice, Sir has been professor of cardiology at DB Pant Hospital, New Delhi, and I was the privileged one to be taught by him in Safdarjung Hospital when Sir was faculty in Safdarjung in 1986. Sir has been president of the Indian Academy of Echocardiography, president of CSI. He has also been the editor of Journal of Indian Academy of Echocardiography. He has contributed more than 250 original research publications in indexed national and international journals. Sir has also been author of several books. So I invite Professor J.C. Mohan, sir, to deliver his talk on the role of SGLT2 inhibitors in heart failure.
Good evening, good afternoon, ladies and gentlemen. Let me just sort out the things which I'm trying to get to.
Your slides are visible, sir. Your slides are visible.
I'm trying to actually look at the. Something is wrong, but just give me a moment and I will be with you. All right. Good afternoon, ladies and gentlemen. I would be discussing a patient of heart failure and discuss with you how to apply emerging evidence with the SGLT2 inhibitors. So this is a 60-year male who had a STEMI in 2010 and was given an ICD for low ejection fraction. And he had a heart failure in 2018, and March 2019, he had paroxysmal atrial fibrillation for which he was ablated. He had two more episodes of heart failure hospitalization, one in 2019 and then last month. And at this time, of course, his blood pressure was low and ejection fraction continues to be 28%. So the first thing I want to emphasize is that this patient had 3 admissions for heart failure from 2018 till now. Hospitalization for heart failure marks a fundamental change in phenotype and natural history of heart failure. This is the data actually from the paradigm study showing that those who are hospitalized for heart failure have mortality which is 6 times high compared to people who have never been hospitalized for heart failure. So this gentleman does have a risk factor like hypertension, hyperlipidemia, and past history of smoking, but nevertheless, his treatment, he is on Sequel or Arni, 50 milligram twice a day, which was reduced from 200 milligram twice a day because of low blood pressure. He's on furosemide 120 milligram a day and bisoprolol 7.5 milligram once a day. Of course, we don't know the heart rate and we don't know whether we should be increasing the bisoprolol to 10 milligram. He's on Epic 7 5 milligram BD. Remember, his CHADS2 VAS score is 3 because he had paroxysmal atrial fibrillation, although he's 60 years of age, but he had heart failure and cardiovascular and coronary artery disease and hypertension. So that gives him a CHADS2 VAS score of 3. He also is on rosuvastatin and estimib, and we will discuss the role of rosuvastatin in heart failure in a moment. There is no MRA in this prescription, right? So what is the guideline-directed medical therapy in HFrEF as of now? And Dr. Anshul Jain took you through that. Of course, the guideline-directed class 1 therapy is ACE inhibitors or ARNI, which the patient is on, beta blockers, which the patient is getting. Patient not getting 2 guideline-directed medical therapies, MRA and SGLT2 inhibitors. These are the 2 drugs which are approved as of beginning of this year, actually. So our patient is not getting actually MRA and our patient is not getting SGLT2 inhibitors. Why is that important? Because you add MRA and you add SGLT2 inhibitors, you can actually create another 50% reduction mortality. This data, this network meta-analysis published by Muthaiya Vaidyanathan from Boston clearly indicates that our patient is only on A plus B actually. And in case you are able to add actually MRA and SGLT2 inhibitor, you can make a hell of a difference to all-cause mortality and cardiovascular mortality by nearly 50%. So it is necessary that we follow guideline-directed medical therapy. The patient is on 120 milligram of furosemide a day. That is a large amount of loop diet. There's a lot of diuretics. Downside of this high dose diuretics is RAS activation, sympathetic nervous system activation, and worsening renal function. And that is one of the reasons why it's easier for hovering around 40. So the diuretics may be good for heart, but they hurt kidneys. And we need to keep that thing in mind when we are giving 120 milligram furosemide to somebody for a long-term basis. Our patient has some shortness of breath and fatigue, but he doesn't have, and there are some episodes of dizziness, so you may not like to increase ARNI beyond 50 milligram twice a day. There's no sign of fluid overload, and you might like to reduce furosemide. That is an important aspect which we need to discuss. Blood test wise, he has no anemia, ferritin level is all right, NT-proBNP is raised, eGFR is 43, blood create 1.8, potassium 5.1. Remember that when we are talking about MRA, this 5.1 potassium needs a lot of caution. LDL 64 acceptable, sodium 141. So this patient has a syndemic of heart failure with the CKD. And we need to keep in mind one thing, that this combination is entirely because of overactive neuroendocrine system, because kidney is the epicenter of harmful neurohumoral overactivity in heart failure. A patient is on rosuvastatin 20 milligram a day. Remember, the data reanalysis in Corona trial suggests that cardiovascular death in all hospitalized for heart failure reduced by 18% with rosuvastatin. So we should continue. And many people believe that statins lose significance once patient develops heart failure. But the data clearly suggests, although first hospital for heart failure is not reduced that significantly, subsequent hospitalization for heart failure are significantly reduced by anti-inflammatory and pleiotropic benefits of statins. So we should continue statin. We did talk about ejection fraction of this patient, about 28%, and he still has wet lungs, as you would see actually the B lines appearing. Okay, so this patient has CKD. Our patient has stage 3B CKD, and data from the Swedish Heart Failure Registry says that nearly 45 to 55% patients with heart failure have CKD. That is data from Western world, and we published our own data last year actually in Indian Heart Journal. CKD in Indian heart failure about 29%, and the reason is our patients are nearly 8-9 years younger. CKD, of course, increases the risk of cardiovascular mortality in heart failure, and the risk could double up if the eGFR is below 30 compared to if the eGFR is above 90. So question actually to us is, how would we optimize therapy in this patient? Increase sequel? Well, he's already having dizziness, 100/70 blood pressure. That is not a very good choice. Stop sequel and give ACE inhibitor. That's also not a good choice, because this patient has been hospitalized 3 times, and we have data from Paradigm HF, which Dr. Hajra did discuss, suggesting that sequel is better than ACE inhibitors. We have a choice of decreasing furosemide and adding dapagliflozin. Well, that looks a reasonably good choice, but I would also say that along with that, adding MRA is also a good choice, provided you can monitor this patient carefully. So what would be the best therapeutic strategy to block the progression of cardiorenal syndrome? Obviously, we actually have to use dapagliflozin. We, of course, would also agree that we should lower the furosemide dose. I would like to say a few words about using MRA. We know that eGFR is 43, serum potassium 5.1, but careful use of MRA is still possible. We know that such are the patients who are usually excluded from using MRA in heart failure, and that is why in best of the heart failure trials, the MRA use is just 70%. This patient may fall in those 30% patients who would not get MRA for multiple reasons, because physicians are overly cautious about moderately reduced kidney function and use of MRA. But there seems to be an avoidable under-treatment with MRA, and I think we should give a fair trial and monitor potassium every 3rd day for a few weeks. And in case potassium remains below 5.5, MRA could be a very good idea in this patient to reduce sudden death and reduce hospitalization for heart death. How does this data come about? This data comes from Alan Mesel's work called COACH study. And acute heart failure patient, like our patient, has been just discharged. He showed that 30-day results of those patients who were added spironolactone at discharge had 45% reduction in death in hospital for heart failure compared to those who were not given spironolactone. However, if the patient were not on spironolactone even before admission, then the benefit was whopping 68%. I would suggest to you that we consider using MRA cautiously in case the potassium level doesn't go up, and of course the create does not go up significantly. So what we did, of course, in this particular patient, you reduce furosemide and add dapagliflozin 10 milligram. Now, the fact is dapagliflozin remarkably effective in individuals who have been hospitalized in last 12 months, and the number needed to treat is 10. That makes it very, very impressive data, more impressive than ARNI, more impressive than beta blockers, more impressive than MRA when you consider somebody who has been hospitalized in last 12 months and you are starting dapagliflozin. So of course, we discharge the patient on dapagliflozin 10 milligram. We decrease the dose of furosemide to 80 milligram and then 40 milligram subsequently. Apixa, bisoprolol continue, rosuvastatin continue. 3 months follow-up shows EGFR practically same, blood pressure somewhat better. And one could think of increasing Sequel to 50 milligram twice a day, which is all right, and he has no longer any dizziness. So we did talk about dapagliflozin use, and of course, the story of evidence for dapagliflozin in heart failure and CKD needs to be considered. There have been 2 big trials, DAPA-HF and DAPA-CKD, and our patient is a prototype of patient enrolled in these 2 trials. So let us quickly discuss these 2 trials. So dapagliflozin affects the cardio-renal brain axis, and because of these multiple benefits, you finally end up improving the function of kidney and improving the function of heart. DAPA-HF was the first trial to study the effect of dapagliflozin in heart failure with reduced ejection fraction. 4,744 patients where DAPA 10 milligram was compared to standard of care treatment, and of course 70% of these patients were on MRA, 95% on ACE inhibitors and beta blockers. So despite that excellent control of HFrEF, DAPA-HF showed a 26% reduction in primary endpoints of cardiovascular death or hospitalized for heart failure or urgent hospitalization visits. And the benefit came up very early within 1 month, and the number needed to treat was also 21. The hospitalization for heart failure, remember this patient had 3 hospitalizations. So our aim actually in this patient certainly is to reduce hospitalization for heart failure. DAPA-HF showed hospital heart failure reduced by 30% and the benefit starting very quickly within few days. Heart failure is hospital for heart failure is an important issue because this is a very important metric of success because hospital and heart failure costs 80% are because of hospitalization for heart failure. Cardiovascular death is also reduced by dapagliflozin DAPA-HF trial, and there was, of course, a 18% reduction in cardiovascular death, despite patients being on ACE inhibitors or ARNI and beta blockers, and 70% being on MRA. As we said, the benefit came up very quickly within 28 days, and you can see that the benefit tends to come up right from the first few days. Our patient ARNI, you might say, will this patient benefit? Well, the data suggests that in DAPA-HF, that those who are on ARNI and those who are not on ARNI got similar kind of benefit. And the benefit is across the whole spectrum of EGFR. So it doesn't make a difference. What is the EGFR? The EGFR of this patient 43. If at all, there could be a slightly greater benefit as you see the left side of the curve. But the curve tends to flatten after 50 EGFR. Anything between 50 to 100, you get same kind of 25% reduction in cardiovascular death and hospitalized for heart failure. The sudden cardiac death in DAPA-HF trial was there in 2/3 of the patients, and ventricular arrhythmia as a resuscitated cardiac death was common. Dapagliflozin actually provides anti-arrhythmic efficacy and reduces the composite of ventricular arrhythmia, resuscitated cardiac arrest, and sudden death by 21%. That way, the patient would not use that ICD that often, and is a good thing actually in these individuals. What about renoprotective benefits in DAPA-HF? Actually, there was a 44% reduction in acute kidney injury, which is remarkable. And but of course, we have dedicated trial like DAPA-CKD, which showed in 4,304 patients with EGFR between 25 to 75 on ACE inhibitor on ARB, showing a 39% reduction in renal outcome, including cardiovascular death, again indicating that our patient actually falls in this category and is likely to benefit with dapagliflozin. This sustained 44% reduction was also present for purely renal outcome. And there was a 29% reduction in cardiovascular death or hospital for heart failure. Now, this data is very similar to DAPA-HF, because DAPA-HF also had almost 1/3 of the patient with CKD, and CKD with or without heart failure, dapagliflozin works. All-cause mortality was also down by 31%. So remember, our patient likely to get more benefit from dapagliflozin because the patient has associated CKD like shown in DAPA-CKD trial. So when you look at the DAPA-CKD trial, all patients get 39% benefit. Patient with heart failure or without heart failure also get similar kind of nearly 40% benefit with dapagliflozin, clearly indicating that our patient is a good candidate for dapagliflozin. How to initiate dapagliflozin in these patients may be one of the things which we have to understand. Dapagliflozin currently actually is a class 1A indication, Dr. Anshul Jain pointed out. And the big advantages, of course, this therapy are that there is early initiation can be done. We saw the data from these soloist WHF. We had data from DARE 19. It is easy to use. There is no titration required. Benefits appear early, and there is a multi-organ protection. So because of that, Milpacker and John McMurray actually in December last year suggested that we should, in the initial step, when you are discharging patient, ideally patient should be on beta blockers plus SGLT2 inhibitors because they don't produce much of the hemodynamic effect. And within few weeks, within a week or two, you can add ARNI, and within another 1 or 2 weeks, you can add MRA. But since our patient was already on ARNI and of course beta blockers, we could add SGLT2 inhibitors straight away. So ladies and gentlemen, to summarize, when you make a choice, you change the future of your patient. And definitely SGLT2 inhibitors are going to change the future of patients with heart failure. But data at the moment applies to HFrEF as far as dapagliflozin concerned. But with empagliflozin, it probably applies to both HFrEF and HFpEF. Thank you very much.
Thank you for very nice talk, Dr. J.C. Mohan, Dr. Hajra, and all. Can we take some questions? Can I ask the chairpersons to?
Dr. Viveka, sir, I have a question to Dr. J.C. Mohan, sir.
Yeah.
Sir, now with the arrival of SGLT2 inhibitors and their great role even in those with preserved ejection fraction, what will be your strategy of the sequence of using drugs in heart failure, sir? Beta blockers, MRAs, ARNI, SGLT2 inhibitors, or it will be otherwise, sir? Some guidance on that.
You could use either of the strategies suggested by the Heart Failure Society of America, where ARNI or ACE inhibitors are first, followed by beta blockers, followed by MRA, and followed by SGLT2 inhibitor. You can use that strategy suggested by Milpacker and John McMurray, beta blocker plus SGLT2 inhibitor first, later on ARNI, and then of course, any which way you do, patient should have all the 4 drugs within 3 to 4 weeks of having been diagnosed with heart failure with reduced ejection fraction. And you should add every 1 to 2 weeks these drugs. So it doesn't make a difference. If within few weeks, let's say 3 weeks, you are getting all the 4 drugs on board, doesn't make a difference what is the sequence. But the treatment would have to be individualized depending upon what are the hemodynamics. If my patient has 90/70 blood pressure at discharge time, or the patient visits me, my choice certainly is going to be in this particular patient, maybe dapagliflozin, and of course, small dose of beta blockers and ivabed. And subsequently, I'll see if the blood pressure looks better, I would probably add ARNI and MRA. But remember, ARNI and MRA actually produce more fall in blood pressure. I also have a situation like our patient, if the potassium is 5.1, the eGFR 43, I would be very cautious about using MRA and at whatever stage it is being recommended. But the important thing which we need to keep in mind all the time whenever we are writing drugs is that reverse remodeling has been shown much better with ARNI, which means improvement in ejection fraction, reduction volume is nearly twice bigger compared to what you see with SGLT2 inhibitors. So in the long run, actually, you can't avoid all these drugs, and you can't say since the blood pressure is 90 to 100, I wouldn't be giving ARNI. You have to be cautious, reduce the dose of diuretics, and of course, add the smallest possible dose and gradually build it up.
Another
There is a
small.
question for Dr. Hajra from the chat box. That is for, so the question is that should we use the same strategy in patients who have, post-transplant heart and going into heart failure? And the second question is that with plethora of new medicine with new evidences, where is at what stage you would say the device therapy should come in?
All right. So heart transplant, we have a concern of immunotherapy. The only problem will be with the SGLT2. The first 3 to 6 months, we have a surgeon in the panel, you can have the opinion from him. The transplanted patients, if you do not have very intense immunotherapy, you can always start with the same therapy with SGLT2 beta blocker, MRA, and your ARNI on the very first day. Now, these immunosuppressions, if you have an improving ejection fraction, almost normalized ejection fractions, then you can go for a de-escalations. So escalating first, then de-escalating, and each patient is different. The immunosuppression, rejections, the continuous monitoring, biopsies, there are so many issues in transplant patient, which is quite different from the de novo heart failure. But again, if somebody is having a heart failure, even after having a good transplant, all these algos will come into play, all 4 drugs like a circle I have mentioned, it is no more a step care. And second question, Viveka, you told me which one?
Device therapy.
A device therapy. Device therapy, they have downgraded to the people who needs pharmacotherapy first. So if you intensify, because the pharmacotherapy is actually increasing day by day in number and technology and more precisions. For example, CCM therapy, cardiac modulation therapy, which can be prescribed on the top of hot CRT, lot CRT, like his bundle pacing, or CRT plus LVV zone pacing, or baroreceptor stimulations, the LVAD, the mitral. So this device therapy is there for some people where the medical therapy polypharmacy will fail. So there is a definite scope for this group of people. So earlier if you do it, it will not be value for money, and it has got a complications. The small heart, if you have a very small heart, it's very difficult to put the LVAD, heart rate 2 or heart rate 3. There is a lot of space issue. But if you have a very large heart, then it's much easier to put this device therapy. So mitral clip, there is a different echo criteria. CCM, there is a different echo criteria. But one day, even your device will fail, you have to go for a transplant. So LVAD, definitely price is an issue, but some patient needs all of them. What do you?
Good. So thank you for nice discussion and wonderful presentation. So we must congratulate all the presenters and the chairperson. So we'll come to the last part of today's talk, that is the end-stage heart failure or advanced heart failure. So may I invite the chairpersons, Dr. Anil Bhatt and Dr. S.K. Mathur. So over to Dr. Anil Bhatt to start the proceeding. Dr. Bhatt.
Dr. Viveka, I would like to congratulate you for organizing this symposium from time to time. I think heart failure is the entity where I think lots and lots have to be done for our country. And to that extent, I think you deserve congratulations to keep talking about this from time to time. Now, coming from the risk factors to stage A, to stage B, to stage C, and as we earlier used to call now, if we reach a stage D or refractory heart failure, then you come to device therapies. Of course, in between you have a lecture where ICDs are not exactly device therapy for end-stage heart failure, but I think we are into the last phase of this chapter, which is for intensive therapy for patients who have, let's say, failed medical therapy. So shall I invite the first speaker, Dr. Viveka? Who's this doctor, or you'd like to introduce them?
Yeah, so the first speaker is Dr. Miten Singh Yadav, who is a senior consultant at our place, Max Saket, and he's a very dynamic young cardiologist, and has been into the device therapies and putting a lot of CRTs and all. So over to him. What does the guideline says? Where should we be, advocating these therapies? So Dr. Miten Singh Yadav, over to you. Please share the slides.
Sir, thank you very much for your kind introduction.
You have to be a little louder. I fail to understand Miten Singh Yadav voice is not loud enough to be heard by everybody. He's a very, very loud speaker anyway. Be closer to the mic.
Yeah, am I audible now?
Not as much as we would like to.
I will try my level best. Is my screen visible?
Yes, it is visible. Go to the slide mode, full screen, and
Yeah, so I'm going to talk in brief about the indications of AICD and CRT. Although Dr. Gupta has briefly discussed about the
I think Dr.
indications.
Viveka, there is no voice. Dr. Mitinder, can you please check your voice system, audio system?
Your voice is again not very well heard. Hello?
Hello, am I audible?
No, it's very muted kind of.
You need to increase the volume from the laptop, sir. The audio volume, I think.
Increase the laptop volume, or
am I audible now?
Yeah, now perfect. Yes, go ahead now.
Okay, so I'm not going to discuss too much about pacing. Pacing is an important part of electrophysiology and cardiology in general. So recently there have been changes in the indications of pacing because there have been many changes in the cardiology. So pacing after syncope, pacing following transcatheter valve implantation, cardiac resynchronization therapy for heart failure, and for pacing-induced cardiomyopathy. Pacing is various infiltrative cardiomyopathies and inflammatory diseases of heart, as well as different cardiomyopathies. And now they have novel tools like conduction system pacing. So there have been changes in the guidelines for pacing, particularly resynchronization therapy in 2021 ESC guideline. I'm just going through them. So we all know class of indications and level of evidence, so I'm going to skip that. So now there have been different indications in this pacing. Primarily, I'll be focusing more towards the CRT and AICD, but there have been changes in the guidelines like pacing after TAVR, his bundle pacing, or CRT, and its safety during the pacing, leadless pacing, and CRT indications. So the current guidelines have the indication for AICD implantation as a class 1 indication when you have to prevent the sudden cardiac death, like structural heart disease with sustained ventricular tachycardia, syncope of undetermined origin, inducible VT or VF at EP study, LVEF less than 35% due to prior MI, 40 days post MI, NYHA class 2 or 3, ejection fraction less than 35%, NYHA class 2 or 3 despite optimum medical therapy, LV ejection fraction 30% due to prior MI, at least for post 40 days post MI, and despite optimal medical therapy and regardless the functional class, or EF less than 40% due to prior MI and inducible VT or VF on EPS. Now, there are class 2A indications, which are like unexplained syncope with significant LV dysfunction, non-ischemic cardiomyopathy, sustained VT, normal or near normal ventricular function, HCM with one or more major risk factors for sudden cardiac death, ARVD, and one or more risk factors for sudden cardiac death, LQT syndrome with syncope or VT while receiving beta blockers, non-hospitalized patients who are awaiting heart transplant, Brugada syndrome with syncope or VT, and catecholinergic polymorphic VT while receiving beta blockers, cardiac sarcoidosis, giant cell myocarditis, and Chagas disease. So I'll just briefly play this video. not going too much into the pacemaker guideline changes. So we will discuss about cardiac resynchronization therapy guidelines. So what is new is that QRS morphology earlier used to be 120 in last guideline, last to last guideline also it has been changed. So recommendation for cardiac resynchronization therapy in patients with sinus rhythm who are having LVVV QRS morphology. CRT is recommended for symptomatic patients with heart failure in sinus rhythm with EF less than or equal to 35%, QRS duration more than 150 milliseconds, LVVV QRS despite optimum medical therapy in order to improve symptoms and to reduce morbidity and mortality. It's a class 1 indication with level of evidence A. And CRT should be considered in the similar profile of the patients with EF of 35% or less and a QRS of 130 to 139 with LVVV QRS morphology. And in order to improve the symptoms and reduce morbidity and mortality. But this has an indication, class of indication is 2A and level of evidence is B. In non-LVVV QRS morphology patients who have got sinus rhythm, heart failure, EF less than 35%, QRS duration 150 milliseconds, non-LVVV QRS morphology despite optimum medical therapy in order to improve the symptoms. Again, it is a class 2A indication with level of evidence B. CRT may be considered for symptomatic patients with heart failure in sinus rhythm with LVF less than 35%. QRS duration 130 to 149 milliseconds, and a non-LVVV QRS morphology despite optimum medical therapy in order to improve symptoms and reduce mortality. But it's a 2B indication and level of evidence is B. And CRT is not indicated in patients with heart failure and a QRS duration less than 130 milliseconds without an indication for RV pacing. So this is a clue. So in AF, what has changed is now they included AF also and AV nodal ablation. So a patient in AF with heart failure, if the patient is patient has controlled ventricular rate or not. If it has, then is a candidate for resynchronization therapy. If yes, if QRS more than 30 milliseconds, it's a class 2A recommendation. And then you have to see that during the AF, the patient is having more than 90 to 95% biventricular pacing. So if it is achieving with controlled heart rate more than 90-95% biventricular pacing, then no AV nodal ablation is required. But if in controlled heart rate also the patient is having less than 90% biventricular pacing, so then you have to ablate the AV node. This is a class 2 indication. Candidates for AV nodal ablation, those who have ejection fraction less than 50%, yes. Then EF less than 40% with heart failure. Indication of CRT class 1, EF less than 40%, LVF less than 50%, heart failure with mild reduced ejection fraction. Now indication of CRT is class 2A. And then you may have to consider AV nodal ablation if you are not achieving biventricular pacing. So a brief video of biventricular pacing, what it is, everybody of us knows, but simply just to make sure that in a bundle branch block, there is a decreased conduction to the one bundle. So suppose here is a left bundle branch block. So left side of the ventricle is receiving the electrical stimulus after a delay, which leads to dysynchrony. And then gradually the contractility of the ventricle is reduced because of this dysynchrony. So what CRT simply does is to compensate this delay, we pace the left ventricular free wall with another pacing wire. So this is the typical RV pacing wire. This is the wire in the CS lead. This is right atrial lead. So now through the LV lead pacing, we can achieve the synchrony in the patients who have an indication of who fulfill the criteria for implantation of a CRT. And we can achieve a narrow QRS as well as synchrony and marginal increase in the ejection fraction, but a significant increase in the functional class or improvement in the functional class. So recommendation of cardiac synchronization in therapy with patients with permanent atrial fibrillation, as I've discussed already. In patients with heart failure with permanent AF who are the candidate for CRT, CRT should be considered in patients with the EF less than 35%, NYHA class 3 or 4, despite optimum medical therapy, and who have an intrinsic QRS more than 130 milliseconds, provided a strategy to ensure biventricular capture in place in order to improve symptoms. AV nodal ablation should be added in case of incomplete biventricular pacing, like less than 90 to 95% due to conducted AF. CRT is recommended in patients with heart failure with reduced ejection fraction, in patients with symptomatic heart failure with AF who have got controlled heart rate and who are candidate for AV nodal ablation, irrespective of QRS duration. It's a class 1 indication, level of evidence B. CRT rather than sustained RV pacing should be considered in patients with heart failure with mildly reduced ejection fraction, those who are already requiring RV pacing. RV pacing should be considered in patients with heart failure with preserved ejection fraction. And CRT may be considered in patients with heart failure with preserved ejection fraction, but it has a level of evidence, class of recommendation 2B, and level of evidence is also C. Patients who have received a conventional pacemaker on ICD who subsequently develop symptomatic heart failure and EF less than 35% despite optimum medical therapy, and who have significant proportion of RV pacing should be considered for upgradation of CRTD. So what we call the significant proportion of RV pacing has been defined a limit of 20% RV pacing for considering intervention for pacing induced heart failure. CRT rather than RV pacing is recommended for patients with heart failure with reduced ejection fraction, regardless of NYHA class, who have an indication of ventricular pacing and a high degree AV block in order to reduce morbidity. This includes patients with atrial fibrillation also. And recommendation for adding a defibrillator to cardiac resynchronization therapy, as we have discussed, in patients who are the candidate for ICD and who have a CRT indication, should be implanted with CRTD. It's a class 1 indication with level of evidence A. In patients who are candidate for CRT implantation of a CRTD should be considered after individual risk assessment using the shared clinical decision. So more advanced age, more cardiac fibrosis on cardiac MRI. So you go more toward the CRTD rather than CRTP. If you consider where to consider CRTP rather than CRTD, non-ischemic cardiomyopathy, short life expectancy, major comorbidities, poor renal function, and patient preferences. There you may have to consider CRTP rather than CRTD. So thank you for your time. Thank you, Dr. Viveka, for giving me the opportunity to present my talk.
Thank you, Dr. Miten, for nice talk and updating about the guidelines. I think we have next presenter, Dr. Rahul Chandola. Dr. Chandola is a very versatile surgeon. He's at our Max Saket and Smart Hospital. He's done first lung transplant of North India, and he's heart lung transplant. Also does all the cardiac surgeries, CABGs and everything, and has done this fellowship in Canada and came back to India. So I think he'll give a full perspective of where does the surgical intervention in heart failure stands, particular reference to the heart transplant and left ventricular assist device, and also in between the role of ECMO in patients who are yet to receive their organs. So he is the last but not the least. So he will be the final surgical word on today's thing. Dr. Anil Bhatt, can you introduce the topic that, in your opinion, where does this therapy and all would stay? So after his talk, we would like to hear from you. So Dr. Chandola, please share your slides and go ahead. Can you share your slides?
Can we see the slides now?
No, not yet.
My screen there.
Open the presentation, then go to the share at the bottom of the screen.
Yeah.
And click on the presentation, then it will start.
So have you logged in from a web browser or the Zoom software?
From web browser, I think. Yeah.
Okay, so you need to give permissions to your web browser. So if there's a pop-up appearing on the near the address bar, please allow that you can share your screen. Or we would request you to please download Zoom and then join the session.
You can make him panelist so that he can join.
Yeah.
But he's already is able to speak, so.
Yeah.
So your web browser might be restricting the screen sharing function.
So I can see the share screen here.
Click on it.
I'm clicking on that. The video is on my desktop, but it's not.
There's a small arrow to maximize the window on the right hand side of the video. Please. If you have logged in from the web browser, your web browser might be restricting you to share the screen. So I would request you to either join from a cell phone or send us the slides. We'll share it from over here.
Okay. Can I send the slides now?
You can mail us the slides. We'll share it.
Please let me know the mail ID.
I've given my mail ID in the chat box.
Sure. Can you just spell out your mail ID? I can't see that.
Or you can re-log in.
Yeah.
Dr. Chandola?
Yeah.
You can re-log in through the Zoom as a panelist.
Okay. Let me do that.
meantime, we can have a discussion on the questions that we have posted on chat box.
Mhm. Yeah, I'll request Dr. Bhatt to
Hardly less than a minute.
take it forward.
Shall we go through? I can see some questions here on my thing. One of them is how we can reduce the chances of sudden cardiac death in heart failure patients with a low ejection fraction. This is from one Dr. Nitish. So, would like to answer sudden cardiac death. Dr. Dharmendra is there? Is not.
Yeah, so I think Dr. Yadav, if you could, you had discussed about the
How could you
devices.
reduce the sudden death in low ejection fraction?
Sir, as we have discussed about medications, so we have got so many medications on board. So we have to first optimize the medical therapy, and they have shown to reduce the morbidity as well as mortality. But despite optimum medical therapy, if the patients are still symptomatic and have a reduced ejection fraction, then comes the role of either device therapy or maybe ventricular assist device. So I think an AICD or CRTD will have a role to play once you are done with the optimum medical therapy and lifestyle modification and everything. Then will come a VAD and will come the transplant. So these are the ways to ultimately reduce the mortality in patients who have got the heart failure with reduced ejection fraction.
I'll just chip in here. I mean, especially for the physicians, I think the physicians are an important arm in the management of heart failure. So unless, they are in the loop. But the question is very nice in the sense that it's well known that now that the negative remodeling or the more towards LV volumes tend to get better with a combination of these drugs. And actually, we know that once the LV remodels in a nicer way with lesser volumes, that itself is antiarrhythmic. So there is more and more data to show that well-controlled heart failure with all the guideline-driven medical therapy with all the drugs in proper dosages. Again, it's important to emphasize that the doses should be proper. It should not just be introduction of their drugs. Patients, if they tolerate sacubitril and ARNI, they have to be taken to the maximum dose prescribed as per the guidelines, that is 200 and 200. Similar so for the beta blockers and ARNI and SGLT2. So a combination of all this actually might reduce the need for ICDs also. And Dr. Yadav, you want to, till we join and want to comment on this, that it's not so cut and dry that you have this indication, this, you put ICD. The role of ICD in non-ischemic cardiomyopathy has not been answered. Most of even the American Heart Association earlier data comes from sub-study of STUD-HEF trial and all. The latest trial with ICD is a Danish trial, as you know, which has shown no benefit in non-ischemic cardiomyopathy at all. And several of these patients in the Danish trial already had a CRT rather. So I think a non-ischemic cardiomyopathy, the role of ICD is yet to be defined.
Sir,
so I think we are ready with the lecture. Yeah.
Sir, I would interrupt.
Yeah.
The last
So,
slide I particularly kept for the same purpose, that where to prefer a CRT-P rather than CRT-D in patients even with the LV dysfunction. One of them first was the non-ischemic cardiomyopathy. And now once we have a tool like cardiac MRI to prove that there is no significant scarring or fibrosis, then we are more confident in leaving them on CRT-P rather than CRT-D, even if CRT is indicated. And after optimum medical therapy. So every guideline has used optimum medical therapy at the first line before any indication.
Good. So I think Dr. Chandola has joined back. So surgeons are, not very good at technology, I would believe. Dr. Chandola, please go to the full screen and start your talk.
Sure.
So please make the slides full screen and then you can initiate your talk. It says your screen sharing is paused. So you might have paused your screen sharing. Okay. So I've got this now. The first option from beginning. From beginning. Okay. Right. So good afternoon, everybody. I'm Dr. Chandola. I'm Dr. Rahul Chandola. I'm a heart lung transplant surgeon, currently working in Max Hospital, Saket. I'm asked to cover the heart transplants and the VADs in this meeting. I will just briefly touch because time is very short. 10 minutes. I've already lost some time. I'll just quickly come to the slides. Heart transplant, as we know, was started way back in late 60s, and it has made really good progress in last almost 50 years or so. The indications of heart transplant, we all know most of the heart transplants are being done for patients who've got cardiomyopathies. Close to 40-45% of patients have got dilated cardiomyopathy or idiopathic cardiomyopathies, and the same number, around 40-45% patients with the ischemic cardiomyopathies. A very small amount of numbers of heart transplants are done for patients with valvular heart disease, and similarly, the patients with the congenital heart disease constitute around 2 to 3% of patients who undergo heart transplant. Now, indications of heart transplant, we all know that the three major diseases: dilated cardiomyopathy, ischemic cardiomyopathy, and the congenital heart diseases. The patients who've got persistent NYHA class 4 symptoms despite maximal medical therapy. This constitutes the majority of patients who undergo heart transplant. Minority of patients are those with the intractable or severe angina symptoms, despite maximal medical treatment, or who've undergone PCI or even the CABG with no respite. Third small subgroup is the patients who have got intractable arrhythmias, not amenable to any medical or device therapy. Now, when should a patient be referred for a heart transplant? We all know that the patients who have got at least 2 hospital admissions in the last 1 year, they have got poor prognosis in terms of 3-year survival, and these patients, will benefit from heart transplantation. And the patients who have got, Seattle heart failure model score, indicating a 20% or more 1-year mortality. As we know that the heart transplant has evolved quite a lot, and the results are excellent. We've been able to achieve the 1-year outcomes as high as 92 to 93% with the heart transplants. So any patients where the mortality, 1-year mortality is anywhere more than 15 to 20%, would clearly benefit from the heart transplant, because the mortality remains very low with the heart transplant, and the long-term outcomes are excellent. As we know, today's time, 5-year outcomes are as high as 75%. 10-year outcomes are as high as 60 to 65%. Any patient with the SHFM score more than 15 to 20% qualifies for heart transplantation. The physicians treating these patients, with heart failure, where the RV dysfunction has ensued, or the PA pressures have started going up, are candidates to be referred for transplant, because we know that these patients, as the PA pressures are going up, if the PVR goes more than 3 to 3.5, that becomes a relative contraindication for heart transplant. Any patient with the transpulmonary gradient more than 14 to 15, becomes a contraindication for heart transplant. So before that happens, patient should be referred for the heart transplantation to get the maximal benefit. Now, any patient with deteriorating renal function because of the heart failure should be referred, because once these patients develop this cardiorenal syndrome and the creatinine goes beyond a certain level, they are out of the transplant list. The patients with significant episodes of ventricular arrhythmias, despite, as I said, maximal medical treatment or device treatment, they should be referred. And the patients with hospital admissions with increasing plasma BNP or NT-proBNP levels should be referred for the heart transplantation. Now, how do these patients, I'm talking from the surgeon's point of view, it's very important, once these patients are listed for the heart transplantation. In our country, especially, we have an organization called NOTO, National Organ Transplant Organization, very fair organization with robust data that deals with maintaining a registry of the recipients and also managing the donors, So once we list these patients with the NOTO, they automatically come in the waiting list. It's fairly simple registration process. Doesn't take more than half an hour. And it's online available. So once the patients are listed with the NOTO, they come in the waiting list. And then we wait for the suitable donor, The donor comes, so the donor hospitals generally, they notify the NOTO, and then the NOTO makes all the arrangements for the organ donation. So what happens is it will inform all the stakeholders, like stakeholders are the transplant physicians, transplant surgeons. They will inform the transplant surgeons according to the wait list, and generally there is a time period of 5 to 6 hours before the explant is planned in the donor hospital. So what it means is after the second apnea in the donor hospital, to the time the patient is wheeled into the operation theater and the organs are harvested, there's a good 4 or 5 hours or even more than that. So during that time, the recipient hospitals are informed. Their team then leaves the recipient hospital, reaches the donor hospital, and the organ harvesting is done. So one important thing is the ABO blood group. The matching requires the identical blood groups. And the second thing is, the compatible blood groups, I should say. And the second important thing is the body size compatibility. Generally, we accept the hearts that are within 20% of the body weight, of the recipient body weight. Important criteria are the antibody screen. We do panel reactive antibodies in all the recipients. These are the antibodies that will determine what are the chances of rejection, the antibody mediated rejection in the post-transplant period. So, for example, any patient with less than 10 to 15% of panel reactive antibodies, they will have less chance of rejection in the post-transplant period. So, but if the panel reactive antibodies are more than 20%, these patients will have a fairly high chance of antibody-mediated rejection in the post-transplant period. And these patients should have a HLA prospective matching. What that means is we will do the donor HLA testing also. So generally, we do not do the donor HLA testing, in the heart transplant patients because the timing is very short. But in the patients where our recipient has got very high PRAs, and we know this patient can have post-transplant rejection, there we go in for HLA typing of the donor, and then we match the antibodies in the recipient to the antigen in the donor. And if there are any matching antigens, antibodies, we discard that particular donor. So the matching is really important. So once the matching is done and we have identified that this donor is a suitable donor for our recipient, the team goes in with all the paraphernalia. This cart contains, the cooling jacket, the instruments, the perfusion items, and then the whole team goes in there to the recipient hospital, and we do cardiectomy. There is a synchronization between the different teams: the liver team, the lung team, the team that is harvesting the kidneys as well as the intestines. So all those teams need a good synchronization. And the last organ to be harvested is the heart, because once the aortic cross clamp goes in, everything stops. So donor cardiectomy is done, as you can see, and then the heart is taken out. It's put inside the plastic bags, which are airtight, and then they contain the preservation solution, and then the heart is brought back to the recipient hospital. Now, the recipient hospital, one team does the cardiectomy. As you can see, this heart is a cardiomyopathic heart, really big heart, bovine heart, and the cardiectomy is done. After that, you can see this heart is really a big heart, almost twice the size of a normal heart. And then the new heart, the donor heart, is then implanted, is transplanted. The anastomosis generally, there are 5 anastomosis in the heart transplant. Said that it is simple. It is simple though, but there are technical details to it, and if the anastomosis are not done perfectly, the patient may bleed to death. And it's really important to be very careful about the left atrial anastomosis, because once this is done, there is no way to go back and look at the bleeders again. So there are 5 anastomoses, as we know. The first one is called the left atrial anastomosis, where the donor cuff, the recipient cuff is anastomosed to the donor cuff, and then the IVC, SVC, pulmonary artery, and the aortic anastomosis. So a lot of anastomosis there, and none should bleed at the end, because any bleeder can really lead the patient to death. Post-operative management, really simple, triple immunosuppression. In today's time, most of the centers are using tacrolimus, MMF, and prednisone. Prednisone generally, we try to get this off, in a year's time, but the patient continues with the tacrolimus and MMF for the rest of his life, with the serum levels of tacrolimus being managed at different levels during the first 1 year, and then maintenance. We keep them really low, just enough to protect, just enough to not have any rejection episode. Endomyocardial biopsy, generally there's a strict regimen, how frequently should it be done. In our Indian situation, there are cost factors, economy plays a major role. So we do not do that many endomyocardial biopsies in the follow-up, but yes, the first endomyocardial biopsy is done before the patient is discharged from the hospital, and then 3 monthly for the first year, and after first year, we do every year endomyocardial biopsies. Now, just to summarize, what I said, will demonstrate it with the cases. This case, as a young guy, 28-year-old with the dilated cardiomyopathy, admitted with very high bilirubin of 3.5. He decompensated in the hospital while we put him in the registration with the NOTO, and we had to use high doses of inotropes to keep the urine flowing. But despite that, he started becoming oliguric, and his PA pressures were very high at that time. He was having pulmonary edema with very low saturation, so had to be intubated. Creatinine also jumped up to 3.5. At this time, the IABP was put, and we were preparing to put a CentriMag device, which is a temporary LVAD device. But he was really lucky. Just about when everything arrived in the operation theater for the CentriMag, there was a call from another hospital, and he got a young heart, which was not very far away from this recipient hospital. So the cold ischemic time was only 3.5 hours, which is the ideal time, ideal ischemic time, especially for the heart. And this is a patient, almost 6 years after the heart transplant. Similarly, another case, 42 years old, patient with dilated cardiomyopathy, low EF, features of right heart failure. He had a liver which was almost like 10 centimeters below the subcostal margin, and his liver scan showed cardiac cirrhosis. So he was advised for a combined heart and a liver transplant. But we know that these patients, once you take care of the heart, cardiac cirrhosis part generally recovers. And with that intent, he was prepared for the heart transplant only. And the idea was to get a good heart, young heart, with the probably a little close to this within that 20% weight range. And he was lucky also, that he got the same heart, almost 15 kgs heavier than him, and a good heart, young 22 years old heart. And this patient was transplanted, and this guy is really running almost every marathon you can imagine down south. He runs for all those charity events, and almost like 7 years post transplant, comes every year for liver for cardiac biopsies, and the detailed evaluation never had any problem so far. All these patients, heart transplant patients, really doing good. Heart transplant really is the only problem is the donor availability, and that leads us to the LVADs. We know that significant advances have been made in the field of LVADs now. The problem is, especially with the heart transplant, is that 15 to 20% of these patients die as they're waiting for a suitable organ. And another 10 to 15% of the patients lose eligibility for a transplant because either their PA pressures are rising, so the PVR goes up. So at the time of listing, their PVR is say 3. They're on the verge, on the borderline. As they progress, 6 months down the line, one year down the line, the PVR goes up to 3.5. PA pressures go up, and they no longer become eligible for heart transplant. Some of these patients will have multi-organ dysfunction, in that waiting period, and no longer be eligible. Many of these patients will continue to develop panel reactive antibodies. So at the time of initial listing, their PRAs would be say 15%, but these patients will require blood transfusion and rest of the medications during the heart failure treatment, and gradually their panel reactive antibodies will go up to very high levels, and they become ineligible for heart transplant. So these patients, if you add on these patients, if you add on both these subset of patients, approximately 30 to 40% of patients who are listed for the heart transplant will not get heart transplant, and they will die or become ineligible. So if you consider that, compare that to therapy wherein you can, there's no dearth of, there's no waiting list involved, and that therapy can be instituted as soon as the patient arrives. So this is what LVAD, where LVAD would be really beneficial, and the survival benefit for the LVAD, if you consider that 30-40% mortality in the patients who are listed for heart transplant, the LVADs have a mortality of less than 10%. At least the 1 year mortality is less than 10%, which is far outweighs the total number of patients who wait for the heart transplant. So now the food for thought is, should we perhaps declare LVAD implantation to be the primary therapy for terminal heart failure? Probably yes. Barring the cost, the rest of the things favor this statement. Because the patients, even the patients who are not fit for heart transplant, say the patients who have got high PVR, patients who have got high transpulmonary gradients, patients who have got high panel reactive antibodies, these are the patients who are not fit, but they are suitable, who are more than 70 years of age. We do not consider them for heart transplantation, but then these patients are perfect candidates for LVAD. So LVAD is an excellent modality, for patients with heart failure, and you can say that there is no other field in cardiology which is experiencing such an explosive growth as mechanical circulatory support for advanced heart failure. So we've got the third generation LVADs available now, even though the experience with the second generation LVAD is tremendous, you know, and the most experiences with the second generation LVADs. So this is a schematic diagram of what the HeartMate 2 looks like, and the patients, you know, as young as the infants up to even the patients who are 80 years of age, you know, they can be implanted with an LVAD, which is in opposition to the patients, you know, where those patients with the heart failure who need heart transplantation. You know, there's an age limit to the patients who can undergo heart transplantation, but there's no such age limit today with those advanced mechanical heart failure devices. We've got HeartMate 3 available now, you know, which is really good to use surgically also. You know, it's easy to implant, and the battery life is also very good. It's very convenient to use and patient friendly as well. Even the data with the HeartMate 3, you know, we've got only 4 or 5 years data with the HeartMate 3 now. But with the HeartMate 2, we've got robust, you know, 20 years data with us now. And the HeartMate and the LVADs are really going to be the mainstay of treatment for heart failure, provided we can control the cost of LVADs. At the same time, the 1-year outcomes with the LVADs are almost same as the 1-year outcomes with the heart transplant, or even better. But you know, the 5-year outcomes may be a little inferior if you compare that to the patients with the heart transplant. So the day when that happens, that the 5-year outcomes with the LVADs are as good as the patients with the heart transplant, probably LVADs will replace the heart transplant, because you know there is so much of dependence on the donor organs with the heart transplant patients. There's no such thing with the LVADs. Patient comes to you, you put in an LVAD, and that's it. You know, it's as simple as a CABG or a valve replacement. So MCS is really a thing of future. You know, if that cost containment becomes possible. You know, with that, I'll just end here. Thank you so much for the patient listening.
Thank you very much, Dr. Rahul Chandora. So I think we had we have overshoot the time limit, and I would request Dr. Anil Bhatt to have a last concluding remark before we wind up, because
Sir, I just wanted to have one question.
Yeah, ask.
So, sir, I just wanted to know, there have been changes in the surveillance of the post-transplant patients, as they've got a denervated heart. They may not feel angina. So old guidelines used to have an annual invasive coronary angiography that has been replaced by so many tests. So which tests are now preferred for surveillance of a coronary angiography on an annual basis, or whatever a time interval? So what are the guidelines for that, apart from graft rejection and tacrolimus level and so on?
Yeah. So we do the endomyocardial biopsy, yearly endomyocardial biopsies after 1 year, you know, and then add that to a yearly coronary angiogram. We also do the immunologic tests, you know, to detect the donor-specific antibodies. If the patient develops any new DSA, that is very, very important, because if there is any new DSA that he is developing, you know, those DSAs could be against the recipient antigen. So it's very important to do yearly DSA assessments along with the coronary angiogram and endomyocardial biopsy, in addition to the routine tests for the cardiac evaluation, which includes ECG, echo, and blood tests. Yeah.
Good. So I think in the interest of time, we will wind it up, and final comment from Dr. Anil Bhatt before, you know, the next time we'll promise that we'll meet again and we'll stick to time.
Dr. Chandora, that was an excellent last session, putting both the things in perspective, the transplant and the LVADs and the advantages of either. Yeah, surely as with time, the cost will come down, and also the technology would further get better. And I think we'll be seeing more of LVADs, because the other thing you didn't mention perhaps is there is this concern about a second malignancy in patients post-transplant at some time down the line because of the immunosuppressives. And that's a big challenge, I believe, after 5 years of the transplant. So with the LVADs becoming cheaper, and if the technology becomes more miniaturized, I'm sure that's exciting days ahead for our patients with end-stage cardiomyopathy. Thank you very much. And thanks, Dr. Viveka, once more.
Yeah, thank you. So thank you. Let me thank all the speakers and the audience for being here on a Sunday morning till afternoon, and the sponsors, Novartis, AstraZeneca, and the, I think, Biotronic and all. So we pledge to fight heart failure with more aggression, with more knowledge, and we'll meet very soon with another session on this, and I'll keep you updated so that you can block your dates. Thank you very much. See you later. Bye-bye.
Bye.
Thank you, sir. Bye, everybody. Bye. Thanks.